Test 1, 2, 3. Test 1, 2, 3.
Good morning. Good morning. I would like to call the meeting to order. Public Health Committee, June 12th, 2023. Welcome all. Please, a reminder that your electronic devices should be switched to a non-audible function. Joining me in Council chambers this morning is Councillor Kazar, Councillor Councillor Clark. I'm thinking Frank. Councillor Wang, Mayor Horvath, Councillor Taddison, Councillor Alex Wilson, and joining me virtually, Councillor Crutch, Councillor Francis, and Councillor Spadafora. Good morning, one and all. Oh, we have a ceremonial activity this morning, and I would like to call upon Dr. Richardson to tell us a little bit about what we're celebrating today.
Thank you, Madam Chair. So this year is the 150th anniversary of the creation of Hamilton's first Board of Health. If we think back to 1873, Hamilton, of course, was an industrial city already grappling with the challenges, unfortunately, of poverty, labor disputes, working on the issues of overcrowded housing, the fight for women's rights, the fight for workers' rights. It's actually quite astounding. There's a lovely piece that's done by a group of master's students from McMaster that tells the story, really, of what was going on around about that time and as the board developed. And many of the issues that they were dealing with then are very similar to the issues that we're dealing with today. Daily life then, of course, revolved around work and family, and the transportation issues were centered on the horse-drawn carriage rather than the LRT or anything like that we're dealing with today. So in Ontario overall, in 1873, the first Public Health Act was passed, and Hamilton chose to set up a Board of Health at that time, and it was established mainly to focus on sanitation and clean water, knowing, of course, we had one of the first water distribution systems in the province. Of course, we've had many, many programs added over that time, everything from supporting new families, screening for dental issues, tuberculosis control. There's all the programs that we currently run today. But one of the things that you look at, and it's really helpful as staff when we're looking at the issues that have been dealt with over the years, is just the requirement for patience and time. And you look back at pasteurization of milk, for example, and it took 17 years for the Board of Health at that time to come to the point of requiring pasteurization of milk. So as we think through issues and think about what's best for our community, that debate, that discussion is essential as we come to understand science and the evolution of science and then make the best decisions for our community. All of the programming, of course, that we do today supports the overall vision of the city to be the best place to raise a child, promote innovation, engage citizens, and age successfully. And of course, given what has happened over the last 3 years, it really is a good time to sort of sit back, reflect on our collective history as a board and as public health staff, making certain that we understand and learn from the past and celebrate the achievements of this board. As well as the public health nurses, public health doctors, epidemiologists, public health inspectors, health promoters, social workers, all of those who have served these 150 years have served Hamilton with passion and dedication. So thank you very much for giving a minute to mark this milestone. I'll let you know our staff are going to be marking this milestone on Wednesday afternoon together to reflect on where we've been and where we're going to go. And we're just very pleased to have your support.
Thank you, Dr. Richardson. When we invest in public health, we invest in one another. We invest in community enterprise, and we secure a more productive, competitive, compassionate, equitable community. It is the opposite, if you will, of a neoliberal approach to consumer choice, because it is recognizing that we are stronger when we act together, and we recognize that our well-being is completely tied to one another. And that when we invest in one another, we're actually investing in ourselves. So that's why we should be investing in public health in a sustainable manner that supports our communities today and into the future. So thank you for your service to everyone in our public health department. Elsie Gauthier, are there any changes to today's agenda?
No, Madam Chair, there are no changes to the agenda.
Thank you. Any declarations of interest? Oh, we must approve the agenda then as presented. Moved by Councillor Alex Wilson, seconded by Councillor Taddison. Thumbs up from Mayor Horvath. Thumbs up from myself. Thumbs up from Councillor Crutch. Thumbs up from Councillor Frank. No, just kidding, Clark. Councillor Esther Paul has her thumbs up as well. That carries 12-0. Thank you all. Any declarations of interest? I see none other than we're intently interested in public health, right? Right. Approval of the minutes of May the 1st, 2023, and of May the 15th of 2023, which was a special public health. It's moved by Councillor Nan, seconded by Councillor Spatafora. Any discussion on those minutes? Seeing none. Thumbs up for me, thank you.
Councillor Nan, thank you. Mayor Horvath, thank you.
Thumbs up for Mayor Horvath, beg your
Councillor
pardon.
Danko, thank you.
Okay, that carries. Lucky 13-0. Thank you. We're on to communications. I need a mover and a seconder to put the items on the floor. Moved by Councillor Paul, seconded by Councillor Wang. Any discussion on any of the items? Okay, I'm going to request Mayor Horvath to assume the chair. Will I ask a question, please?
Absolutely, please go ahead.
Thank you. I would like to ask a question about 5.6. It is correspondence from my previous employer, Chatham-Kent Public Health, respecting universal no-cost coverage for all prescription contraceptive options to all people living in Ontario. I'm very pleased to see this, the recommendation being that this is endorsed. But I would like just some context, if I could, through the chair, to Dr. Richardson. I noted in British Columbia, as of late, they made a move to ensure that contraception is, I believe, no cost. And I was wondering if you could describe the landscape of access to contraception across Canada and here in Ontario at present, please, through the chair.
Through you, Madam Chair. I don't have a good sense of what it's like across the country. We can certainly come back to you with that. Here in Hamilton, there is availability of low cost, no cost through the 25 and under program. For those that are over that age, they are able to access low cost, not no cost, contraceptives through our programs, where we do just a simple cost recovery and is fairly low cost. I don't know if Jordan knows the exact quantum. I think Susanna, his manager, was actually covering him for him at the end of the week. And so we can go back and get the exact cost for you and bring that back. It's not been an issue from the clientele that we serve. It's not something we hear as a barrier in terms of people coming forward. But of course, when we look at those issues, no cost is of course more accessible than low cost. And so happy to sort of send a follow-up with some further information on the landscape.
Councillor Wilson?
Through the chair to Dr. Richardson, I'm not familiar with the low barrier access landscape here. Could you just describe it, please?
Through the chair, Jordan Walker, Director of Communicable Disease Control. So through our public health services programs at our clinical sites, we do provide prescription contraception, but it's provided at what is essentially cost. So the cost that it requires us to acquire it, we are able to provide it directly to the clientele at that sort of bulk purchasing price that we're able to obtain it. So there's no sort of dispensing fees that you might get if you went to a pharmacy, et cetera, that are tacked onto that. It ranges depending upon the specific type of birth control from about $7 for a 28-day pack up to, I think the most expensive appears to be about $19. But again, I could get back to you with more specifics on that.
Thanks, Director Walker.
Thank you very
Councillor Wilson?
much. If I could ask, sorry, where is that accessed through the chair?
Through the chair, that is currently accessible at our Public Health Services Sexual Health Clinic run at the David Braley Center, David Braley Health Sciences Center.
Thank you. So I did heed the counsel offered by Dr. Richardson that to date, we have not had issues raised about accessibility, both in terms of location and cost, and both are, we have not heard, because that's just one place for the entire city. Is that correct, through the chair?
That is correct, though I believe this is also, that is also accessible through our harm reduction program as well, as able to provide these services, which is at various locations throughout the city. I don't have them in front of me, but they are available at a number of locations across the city.
Finally, if I could ask Dr. Richardson, I'm reading from the, pardon me, the Canadian Pediatric Society and their opinion on the importance of universal access to no-cost contraception for youth and all Canadians. I'm wondering if you could offer us a public health opinion on the importance of access to no-cost or low-cost contraception and what that means.
Dr. Richardson?
Through you, Chair. The OHIP Plus program has brought in no-cost contraception for youth, for those under the age of 25, which has been very good and indeed a very important program to reduce barriers for teens, for young adults, where income may, of course, be a challenge, but also the issue of needing to speak with others in order to gain access to the funds to purchase it. It allows them privacy in making those decisions and obtaining what they need. For those who are over that age, we know there are those that have barriers as well to obtaining those medications. And indeed, you know, I'm cognizant along the way people have thought of them as lifestyle medications and really put them in the same sort of venue as cosmetic procedures or those sorts of things, which I don't think is at all appropriate for this piece. So absolutely, continuing down the line, I mean, for me overall, it's an issue of pharmacare. This is not the only medication that one should have access to and have free access to, especially if one is low income and in need of these, to maintain as healthy a lifestyle as possible. So I tend to go to the broader issue of pharmacare and ensuring access on a broad range of medications. But this, of course, would be one of those that's important to ensure access to.
Thanks, Dr. Richardson. Councillor Wilson?
Thank you, Dr. Richardson, very much. If I could, please, Mayor Horvath, I just would like to cite for the public record, of course I can't find it now. Give me one moment. Blah, blah, blah. Apologies, everyone. If I could read from the Canadian Pediatric Society on this subject, access to contraception is recognized as a basic human right. Ensuring that women can choose whether or when to have children means they have greater control over their bodies and futures. Unintended pregnancies may derail life plans, particularly for adolescents and young adults. Adolescent parenting is associated with lower lifetime educational achievement, lower income, and increased reliance on social support programs. Apart from the personal costs, unintended pregnancies are a costly burden for Canada's health and social service systems. Thank you.
Thank you, Councillor Wilson.
Appreciate that.
Chair, back to you.
Thank you. Any other comments or questions on the communications as presented? Seeing none. Elsie Gauthier, did I have a mover and a seconder?
Councillor Pauls and Councillor Wang.
Thank you.
Councillor Francis.
Thumbs up from Councillor Francis. Thanks. That carries 13-0. We're on to staff presentations. Item 8.1, Collective Impact, Healthy and Safe Communities, and the Greater Hamilton Health Network 2023 Update, Report BOH 23020. Dr. Richardson is going to be here to present on this item along with Melissa McCallum, who is the Executive Director of the Greater Hamilton Health Network. Good morning.
Good morning. Thank you very much, Chair. This is Melissa McCallum. I think you have met her before in virtual format, perhaps, but very glad that we're both here today to talk about the GHHN. We're going to give you some context on how our local Ontario Health Team, which is called the Greater Hamilton Health Network, came to be and how it has evolved over the past few years. Melissa has been involved since the very beginning, so has all of the history, as have myself, and Angie Burden as well sits on the board for the GHHN. We're going to talk about the unique role that Healthy and Safe Communities Department in particular has played to date and highlight the collective impact that the GHHN has been able to achieve in the short amount of time since it was established. We're going to continue to provide updates to you on an annual basis, so Melissa will be back every year to talk a little bit more about the GHHN, to report on where it's going and the work that we do together. This is why we get the clicker, Melissa. There we go. Over to you.
Hi, everyone. Thanks for having me. I wanted to present a bit of a primer on Ontario Health Teams and where we're at in our communities. So the concept of Ontario Health Teams was born in 2018, and that's the year that we saw the LHINs dissolve and Ontario Health really collate most of the health-serving agencies across the province. As the LHINs were dissolved, they planned Ontario Health Team models that would locally look at how to integrate community care more closer to home. So we used to see those LHIN boundaries quite large, Hamilton, Niagara, Haldimand, Brant. We were now coming closer down to Hamilton and planning at that level. The provincial government acknowledged that although care was high quality, we needed to provide a system that was better integrated and connected to local providers. And this vision was going to be accomplished through the vision of Ontario Health Teams. I do want to mention that, previous to Ontario Health Teams, I did work at the HNHB LHIN, so was part of the LHIN and Ontario Health, where planning was more at the regional level, oftentimes siloed based on the sector that you were planning on, and also siloed based on who was your funder. There are several funders of ministry-delivered health and social services, and sometimes those didn't feel as connected. So the Ontario Health Team vision was to really bring these services all together. It was a new way of organizing and delivering care locally. Under this new model, it was determined that health and social and municipal services in a geographical area would plan together, regardless of where they provided care, regardless of who their funder were. We were going to work as one coordinated team. So the intention of the model of Ontario Health Teams was to really move away from disconnected siloed planning to where we were working as partners across sectors, across systems. This not only transforms care for patients, but transforms care for providers, making the system easier to navigate. In addition to more coordinated care, this approach allows healthcare providers to be more actively involved in shaping how healthcare is delivered. At the heart of Ontario Health Team models is ensuring that patients and communities are part of co-designing the healthcare initiatives that will be delivered in their local communities. We are able to approach diverse and complex needs of our communities by involving communities in this co-design model. So the Greater Hamilton Health Network is the name for Hamilton's Ontario Health Team. I'll say in 2019, Hamilton proper responded to the call from the Ministry of Health to put in an application for our own Ontario Health Team. At that time, we saw over 20 to 30 health and social service providers come together to put an application in. This was heavily involved with the City of Hamilton, Public Health, and Healthy and Safe Communities. We were one of the first Ontario Health Teams approved in November of 2019. I want to note that our original application focused on Hamilton in general, but in February of 2021, we were asked by the ministry to include the regions of Niagara Northwest, which is around the Grimsby, Lincoln, Smithville regions, and the Haldimand region. So it was at that time that our proposal as the Hamilton Health Team really morphed into the Greater Hamilton Health Network to reflect that larger geography. Our OHT, the GHHN, is actually one of the largest OHTs in the province. Our attributed population is around 700,000 people. We also have considerations for on-reserve and urban Indigenous communities, as we're very close to Six Nations and Mississaugas of the Credit. In terms of governance, when Ontario Health Teams were first developed, it was actually self-determined by each team how you would govern your own model. The only requirement was that you included health sector and social sector leaders, as well as patients at the co-design table. In Hamilton, we felt that we already actually had very mature partners and structures in place, that we actually moved to a model of incorporating our OHT in 2022. We spent the time in 2020 and 2021 understanding models of incorporation, doing an extensive health equity framework report, and then deciding that in order to progress and mature our OHT as far as we wanted to incorporate the team. As of right now, we are the only incorporated Ontario Health Team in the province out of 54 teams. And in November of 2022, the ministry announced that now every single Ontario Health Team would incorporate into a not-for-profit entity, making our model the gold standard for moving forward in the province. In terms of governance, you'll see here, we do have an 18-sector board of directors, heavy involvement from those health leaders across important sectors and social care agencies. On our board, Elizabeth Richardson and Angie Burden sit as having 2 seats. We ensure that we have patient voices, 2 seats on our board. And then we have, open, independent community seats to ensure that we're filling out the diversity of the voices and needs in our communities. The collective vision for the GHHN is really providing a healthier and equitable, seamless continuum of care that actively improves population health and meets the needs of the individual community. Our strategic plan involves a mix of provincial and local priorities. We have 5 key focus areas, and that includes integrated population health, where we see the clinical design of integrated care pathways for people who live in our catchment, governance, continuing to evolve that structure. A large part of the work that we do is in primary care, ensuring that everyone in our community has a medical home, that they receive comprehensive and full continuum of care. We still manage, along with public health, an integrated COVID-19 response and recovery part of the work. And we see a large part of work under digital care, including patient navigation. These 5 key priority areas are overarched by 3 important areas that we saw as a Hamilton, Haldimand, and Niagara Northwest team as being extremely important. And that is ensuring that there's patient and engagement in all of the sectors. So you'll see the kind of 3 overarching circles there. So patient and community engagement is built into each and every one of those 5 pillars. We take an equitable healthcare approach, knowing that we will be more successful with integrated care when we focus on those that are hardest to serve. And all while doing our activities, being mindful that healthcare is a huge emitter to environmental concerns. So we want to ensure that what we're doing is environmentally friendly and progressing a sustainable approach as we move through integrated care activities. There is a lot of work going on at the GHIN. This is a sample of all of the work streams that we have right now, which span digital health, including getting primary care providers up with online appointment booking, to helping patients navigate the system. In integrated population health, we see focuses on women who are homeless, mental health and addictions, making sure that seniors going home from the hospital are connected to a connector. Living Healthy in Congregate Care sees a whole bucket of work under long-term care and residential care facilities. We have a large patient and engagement pool. We have built our OHT centering around health equity. In 2021, we spent the first 7 months of that year developing our OHT, knowing that the voices of those that are not often heard needs to be at the center. Primary care is essential. We want everyone that lives in the Gin catchment to have a primary care medical home. We are continuing to build out our incorporation, and we continue to integrate with other areas of our OHT, like Haldimand. The Greater Hamilton Health Network has over 40 to 50 providers as part of its work, and we will only achieve the diverse needs of the community in an integrated way by continuing to evolve and expand with our partnerships. You do not need to be a health service provider or a funded social service provider. The GHHN works amongst charity organizations, church groups, community groups, anyone that's part of the integrated care work. We know that all of that continuum is important to ensure that everyone is living to their full potential. At maturity, we don't know exactly how OHTs are going to evolve over the next 5 to 10 years. But we are working towards receiving a funding envelope for our providers to disperse equitably throughout our community. And we really truly believe that our governance work is setting us up for success. I'm going to hand it over to Elizabeth about population health.
So Melissa's spoken a lot about the importance of integration across not only health partners, but across health and social service partners, across everybody who wants to contribute to those ends, and how municipal partnerships are very important. So we each have a unique role to play, but we need to do that together, integrated as a team. So we have a number of areas of expertise, and one of the things we talk about a lot is this population health approach. I can tell you when I first started working in public health, population health was something that other people did over there when it came to the health system, even when it came to social services. And while municipalities were doing it in spades, it wasn't really known as a population health approach. But overall, we have this approach in looking at the full population. So if you see these three curves, we're looking at the health of the full population, and then we have different mechanisms that can help to propel that forward. The curve at the bottom, the yellow curve, is really the work of looking after those who are ill, those patients who need care, and helping to improve their health. The next curve is looking at patients who may have some issues but aren't really aware of them. So you think about screening for diseases like cancer or diabetes. You think about people who are coming forward for care for one thing but don't recognize that they have something else that is really important for them. So it's outreach to those groups to talk about what else can be done, what else can be added. And so much of the population health management approach that is being done with primary care that the GHHN is leading is really focused on how can we move both of those curves forward. And then all together, and particularly with the municipal role, shifting that top curve, which is really how can we improve everybody's health? How can everybody, not just those who have an illness or who may be in early stages and we're screening for illness, become healthier, but how can everybody be healthier throughout their lifespan? And so that population approach is very important as well. You'll know that at the municipal level, there are a number of things that we do around the social determinants of health, whether that's around health promotion strategies as well, or around providing income to those who otherwise would not have it, or housing, or those sorts of things. And then, as I said, the GHHN focusing very much on the clinical providers and how they can reach out further. And then finally, as we continue to reflect and work with people who present for care, whether that's in an emergency department or in an office as well. So all three levels of that work are very important in order to move home or move further the health of our community, and to do so in an equitable way. Just for the sake of time, I'm going to just leave you with those particular pieces and have it come back to Melissa on collective impact.
So the model that we use when working with other providers in the community is really on a collective impact approach. Everyone is bringing, top of mind their expertise and what they can offer to improve population health outcomes. I just want to highlight a few of these outcomes in the next few slides. Firstly, Councillor Wilson, you are speaking to my heart when you bring up contraception care. Over the last 2 years, the GHHN, in partnership with many providers in the homeless serving and social sectors, have started what's called Women's Health Drop-In Clinics. So 2 times per season, we hold these clinics at a shelter or day space that women are often congregating for food or shelter support. We put, 20 to 30 services in each of these drop-in days so that women can come and low barrier access anything from mental health care, primary care, wound care, STI testing, contraception, food, donations, clothing, all in one place. No OHIP card is required and no appointment is required. We work across so many organizations that come with what they have to provide care for homeless women across the city. To date, we've served almost 500 women through these days. There's been incredible stories of integration care. For example, last Women's Health Homeless Day, we had a woman who was able to be tested for hepatitis C on the spot by a point of care testing and go to the next booth to start her treatment. That included not having to go to any other appointments across the city, not having to deal with transportation, but providing that low barrier support where women are at in the moment. This model has been very successful for us because of all of our partners. And in 2022, we won the top award at the International Conference of Integrated Care in Denmark for this service delivery model for homeless women. Last year, we also worked with partners like YWCA and Birthmark to create an abortion care pathway. So that is now fully mapped for the City of Hamilton and available on the HFAM website. And this year, we're going to focus on low barrier contraception access pathways that will be available to every provider. When it comes to digital health, the collective impact here is really about better provider and better patient experience. Over the last few years, we have worked to connect not only patients to access their records and care, but for providers to speak to one another. We've received almost $2 million in digital health funding across 16 digital health initiatives over the last year. And this is really improving patient experience by connecting them, but also ensuring that as we move forward with digital, we keep an eye on digital health equity as well. We don't want to marginalize people as we push through a digital and virtual health model. In terms of better value, we're always looking to improve the costs in the system. The GHHN, in partnership with community providers, created a Let's Go Home program, which really meets connectors in the emergency departments with older and frail adults to connect them with bundled community care services so that they can go home and reduce admissions. Setting up things like food appointments. That connector meets that person in the emerge and goes home with them for 4 to 6 weeks to arrange that care, not only for the patient, but for the caregiver is seamless, one point of contact. And also it's been an incredible experience to see, seniors go home with that wraparound support instead of now having an admission potentially and then going home to a siloed system.
So one of the other things that Melissa mentioned is around our COVID-19 response. And we've had a long history of working together across the health system when it comes to infectious diseases and emergencies. This really began in the late 1990s as people were planning for pandemic influenza, knowing at some point we'd have a pandemic of some sort. This was very much tested with SARS in 2003 when the healthcare community came together to serve our community, look at how did we understand provincial directives, how did we understand the epidemiology and spread of the disease on a local level and make decisions together. During H1N1, we got a chance to try it out again and continue to improve the way that we were responding. And when it came to the beginning of the pandemic this time around, we reactivated those committees that had been in place across the system. So together, serving the city as a whole, looking at how we could look at everything from testing through treatment to case management, outbreak management, infection control advice, bringing together the expertise that we have at McMaster in our hospitals locally, here in public health and primary care as well. And so as that continued through and had the partnership around the table, we looked at how we can take this into the GHHN, into the Ontario Health Team, so that together, again, it's ensconced, it's within the work of that group to do the emergency management that we do. So we now have a structure together with the OHT to look at how we do emergency response as we go forward.
So Happy to present those key messages and the success of the GHHN. I think that what we want also to say is that there are, growing complex issues and that you all know about within our communities. Things like mental health and addictions, the opioid crisis. We have 55,000 people that do not have access to primary care in the GHHN. Those are really important issues that we're going to have to tackle together. But I think that we have a strong foundation to do that, moving forward. And that this collective impact has been an incredible model to looking at complex problems and dealing with them as communities. I'm always happy to answer any questions, and please feel free to contact me at any time. We do want to move into, community and neighborhood strategies as we move forward as well. So looking forward to working with all of you.
Thank you both. That's the conclusion of your presentation. Great. Thank you. That was very informative. Thus far on the speakers list, I have Councillor Wang, Nan, Alex Wilson, and Councillor Clark. Councillor Wang.
Thank you. Thank you for this presentation. I wonder if you can give us a fundamental overview of how this Public Health Committee interacts with the Greater Hamilton Health Network, which formerly used to be the Local Health Integration Network, which is now part of the Ontario Health Team. Do you see how we have a lot of acronyms that are kind of being thrown around? I would really like just a very bare basic, how does this committee connect with the GHHN, which then connects to the service providers? I'd just like that understanding.
Thank you.
Through you, Madam Chair. So absolutely the piece about the alphabet soups that we throw at people all the time. And so the OHT, the Ontario Health Team, which for Hamilton is the Greater Hamilton Health Network, it doesn't represent the whole of the geographic area that was the LHIN. Just wanted to draw that distinction between those two, but really focuses on those areas that Melissa spoke about, West Niagara, Haldimand, and Northwest Niagara, and Hamilton. And so for that team, it does have 2 members on it that are members of the bureaucracy here in Hamilton. And so Angie and myself formally sit on it as members of the board. And so there is that relationship there. There is also staff who sit on many of the working groups that carry out the work. And so this is very much representative of the integration that we want to have. We want to have people sitting on those tables together, working out issues together, bringing all of the resources and intelligence that people can bring to solve those problems. So we have a connection at that governance level. We have a connection as well at the staff level. And then as you see in things like what's the clinics called? Melissa, I'm having the women's health clinics. We actually are there on the spot, doing things for people with the services that we can bring. So it's through those different levels. For the board itself, for the Public Health Committee and for Council, that relationship we've agreed on, Melissa coming annually to go over, what's going on, stay connected with it. But we also do see, as Melissa was saying, around neighborhood work, and as work goes forward at that level, that the involvement of individual councillors in that work to understand their communities, to understand what can be done is going to be important as well. Anything you want to add, Melissa?
No, that was great.
Thank you. Through you, Chair. I think I understand that perspective. I think that the whole point that I'm trying to get at is the federal government lays out healthcare. It gets downloaded down to the province. The provinces now provide funding to the LHINs, which are currently still active. No, they are not active. They go to the all the Ontario Health Teams then, right?
No, so the LHIN staff and model of care got transitioned into Ontario Health.
Okay.
And Ontario Health then disperses, accountability agreements and funding to the agencies where the LHIN used to do that.
Okay.
OHTs get a small portion of one-time funding per year, about $750,000, and that is not for service delivery, but that's more for project management, ensuring that the team is wrapped around, all of the initiatives to push forward.
Okay, so then if I had to think about this from a flowchart perspective, the province then puts it into the OHT, which then disperses the funds into all of the service providers, and off to the side where we have governance is all of the public health committees or the councils and the boards of health that are associated with Haldimand, Niagara, and Hamilton are off to the side that are directing. I'm sorry, I just needed that as a flow chart sort of can you give me that sense of,
Yep.
is that the right sort of course of action of how funds flow through versus how the governance comes in?
Yeah, so I would say that funds flow right from the Ministry of Health
Right.
to Ontario Health. Ontario Health disperses the funds to individual agencies.
Okay.
But OHTs come in to locally plan. I don't hold the funds for like individual service agencies yet. I have been given, buckets of funding to determine, well, what's best for your community? And it feels like they're moving towards that approach at maturity. But you're right, on the side is, within our OHT, 3 boards of health, right, that are looking at their own communities and have their own priorities. I would love to strengthen that integration together. We are all, as corny as it is, we're all in this together, but we need to strengthen those relationships so that you all know what we're doing and on the ground, so that when you're hearing from your constituents, you can say, actually, I've heard of a women's health clinic, or you know what I mean? So just strengthening that communication, and happy to help in any way that I can do that as well for all of you.
Okay. Thank you for that explanation, and I hope that at some point we can also get like a chart. That way it might be easier to share with our constituents, because I can almost imagine the types of questions that might come forward. Well, what does the Public Health Committee, which at some point we will be doing an audit as to what's the best way to form this committee, which sounds a lot like what you already have at the GHHN, where you have independent members, you have all of these different stakeholders. So I do want to be clear to constituents how this works together.
For sure, and it's been confusing over the last few years. We've had lots of name changes as each government has changed, so I appreciate that, and I can definitely help with a flow chart you can distribute.
Okay.
Councillor Wang, if you would permit me, I believe GM Burden would like to also offer a comment.
Thank you. Angie Burden, General Manager of Healthy and Safe Communities. Through you, Madam Chair, to the councillor. I think it's also important to recognize that across the city, we receive funding directly from the Ministry of Health, which flows funding to Ontario Health for a variety of programs. So Dr. Richardson had talked about some of the programs that are funded directly through public health. We also have in our Children and Community Services a home management program that receives funding. The entire Hamilton Paramedic Service funding is 50% tax levy and 50% Ministry of Health. A significant difference with the Ontario Health Team is that there's no accountability for patient care or outcomes apart from how do we work together better. Each organization, whether it's the city or a funded hospital, maintains that autonomy for patient care and those deliverables. So I totally agree with Melissa around getting a chart out to see how that funds. We also have home care then that is funded by Ontario Health through home and community care support services. And so there's a variety of, avenues for that funding and care delivery. Thank you.
Thank you. Not complicated at all. Councillor Wang.
I think that brings me to some more complicated questions then, through you, Chair. What we've heard is that many hospitals are over capacity, and a lot of the times they cannot free up beds because there are literally no places for people to go, which strikes me that that is something you've identified in your strategic priorities as the going home thing. Sorry, I'm just trying. Let's get home initiative from the integrated public health pillar. How do we do this? Who takes the lead in this? Because when I hear that there are challenges with getting people to homes, which strikes me that that's part of our healthy and safe homelessness ending strategy, but it has also been identified here as one of your strategic priorities, but that means that you are doing it from a different sort of level. So who's taking priority and who's taking the lead in something like that? Through you, Chair.
And Councillor Wang, happy to put you on for a second time. So thank you.
It's a great question. I'll say that the OHT model, we're integrated with hospital, with with public health, with the city. So we have an understanding of the various initiatives. How they all tie together can be really complicated sometimes. But I'll say that the OHT vehicle has really been the container to have those discussions about what's going on in the system and where do we need to put resources, time, and effort together. We have those collaborative discussions. You know, at the board level, the acute care hospitals are there as well. So it's really actually, you know, I'll say that at the OHT, you know, I've got 7 staff. I can't possibly, you know, manage and service lead every single, you know, complex issue in the city. So I depend on service agencies to have this shared leadership model where we do, you know, collate and collaborate on what do we want to get done. So all of the initiatives that I do are in partnership with all the other sector agencies. Nothing I'm doing is alone. And I think that that's actually been quite powerful. I think that we do have to move to a model where we understand which lane everybody is in. And I think that that will progress under this notion of the Ontario Health Team model. I'm a big proponent for it because I think it's working, you know. I probably won't have a staff team of 50 in the next year, but I'll need to depend on Elizabeth's team and Angie's team and the hospital's team to understand, okay, we've got finite amount of resources. Where are we going to put them for most in need?
I do have more questions, so if I could be put on for a second time.
Thank you very much. Councillor Nan.
Thank you and good morning, and thank you for the overview, Melissa and Dr. Richardson. Just a few clarifying questions, if I can. So over towards appreciating Councillor Huang trying to get some structural clarity and also fan flowcharts, looking forward to receiving that. But in terms of the low barrier support and meeting people where they're at, completely, wholly loving the commitment in principle in terms of ensuring patients have access to the supports they need, what they need, where they need it. Wondering, in the demonstration project with women's health, how that came to be prioritized, and also has the Greater Health Network looked at other populations that have been significantly underserved as it comes to health? And for me, that speaks to our non-binary and trans neighbors as well. If you could comment on that, and then a couple more questions. Thank you.
Yes, thanks, Councillor Nunn. In 2020, when we were looking at populations that, you know, were equity seeking, I'll say that from the very start of our Ontario Health Team, we determined that we were going to serve those that were hard to serve and not layer on more service for those that have it already. So during the pandemic, you know, in working with our city and social providers, we actually saw an increase in women becoming homeless, pregnant women and older women. So we collated a Women's Homeless Secretariat working group amongst various providers to say, what can we do? And how can we bring care to this, you know, complex community of women? So it was very organic. Everyone came to the table and said, well, I can provide this and I can provide that. And we started to collate, you know, these low barrier drop-in days to be where places where women were collating during the, congregating during the pandemic. So places like the YWCA, you know, Willow's Place, Good Shepherd, and then utilizing people within the system to bring forward their expertise. To be honest, it's actually, you know, an incredible scene to have providers step up and be like, I'm a primary care provider, I'll do pap smears. You know, Marchese Pharmacy saying, I'll donate all the contraception. It's an incredible, you know, the best moment I've actually had as part of this team is to see these days come together because everyone brings what they have within their own funding buckets, within what they can provide. So, you know, those days were really born out of the fact that we have a homeless crisis, women need care, we want to ensure that it's low barrier. I can't focus on everyone all at once. So we decided to choose the women and, you know, gender diverse stream first. In terms of other populations, of course, I really would encourage you to check our website. We did an extensive health equity report on specific populations within Hamilton, you know, that deserve better, safe access to care, and that includes our trans population. The GHHN has created a trans health community of practice where people can come online and get advice as to how to, manage trans care patients in the community. It's a safe space for people to discuss, with other mentors, in the health sphere about providing trans health care. We've recently actually, as a board of directors, just approved a gender affirming care position statement, which really, health equity for all. This is a human rights issue, and we want to be able to provide that care for our trans and gender diverse individuals. We've also put in several proposals lately to expand our trans health clinic at Compass Community Health Center. So I would say that the trans and gender diverse population is actually, top of our list when we're looking at expanding care.
Great. Glad to hear it.
Councillor Nan, beg your pardon.
Thank you. Next question is data. So you mentioned the population health outcomes, and Dr. Richardson, you mentioned it as well. And in terms of your current steps and next steps around mapping the care system, could you speak a little bit about what does it look like right now in terms of your efforts to get an accurate picture of how the systems currently coexist and what's to come?
There is currently a lot of mapping going on. We're actually first starting in primary care. We've just successfully mapped every single primary care provider in this city and where they practice. And we're hoping then to connect, kind of geo hubs to social care across the city, starting in a few high-risk wards. At the end of this week, we're actually handing in, a $20 million proposal to the Ministry of Health to expand team-based primary health care based on, priority populations in this city. So, we're constantly working with our health and social providers to map out care. One thing that is part of the OHT work is that we don't start clinical pathways without understanding what assets we already have in the community. Healthy and safe communities, neighborhood mapping and asset mapping has been extremely helpful, looking to help update some of that. But we need to understand our assets before we move forward. And I think sometimes, we can feel like there's not enough resource, but when you look really into community and all that people can offer, there's a lot there. We just have to make sure that we're working together and not duplicating services.
Wholeheartedly agree, and looking forward to ongoing conversations with the team in terms of that mapping exercise and how the city could play a partnership role. Often my colleagues around the table hear me talking about the need for an integrated health and social service model that is not only focused on meeting our current population needs, but is also enabling us as a municipality to think about what does future planning look like, right? Where are we anticipating not only population growth, but population changes as well? So is there anything you can share there in terms of how are you anticipating the potential here for measuring population health outcome changes? Like, how are you measuring not just collective impact, but like specifically, like as a result of this model of care and approach, we have seen X marked impact in terms of our population health.
Perhaps I'll get started and hand it back to Melissa as well. But, this speaks to our population health assessment piece as well. And as you heard Melissa talk about several of the things they're doing, there is still work, there's still a bit of siloed work going on with us doing population health assessment. The OH is doing a lot, Ontario Health is doing a lot of data collection and mapping and review. The team is looking at it. And so we're really looking forward over the next couple of years of bringing all of those approaches together. We do this larger scale population health assessment that looks at our whole population, and that's what we'll be bringing back to you at the beginning of next year, looking at what are the key issues that are affecting our population, what are the risk factors that are affecting it, and then this will also go into the OHT, into the GHHN to talk about the population as a whole. And Melissa, I don't know if you want to add where you're at further with that.
Yeah, this is a partnership amongst many, kind of data strategies. There's lots of data out there. We need to make sure that we're using it to our full potential. And public health's been an incredible help with that, especially when we look at the health, down to a postal code level. This is an increasingly difficult space because measuring health and measuring, actual well-being can be challenging. My dream would be that we'd have one ministry, that there's housing and health, interconnected as one, planning as one, so that we can understand the full potential of people living in this community. We're not there yet, but, we at least are starting to work together in a bit of a different way and looking at what's most meaningful to patients. How do people and residents of communities actually say, their health needs have been met? That's not always what ministries track all the time. So having that balance between what communities need and what we want to drive as, population health measures. We do commonly look at things like screening and vaccination rates. Those are really, well-known metrics, but really expanding those metrics into what's most meaningful to communities, I think, is really important. I know all of us probably don't want another third iteration of the Code Red report that shows the similar health outcomes of our populations, really trying to move that needle by working differently together.
Yeah, that last piece is really key and I think important. Often when I hear from residents in Ward 3, it's that piece around, what difference are we making with the investments that are coming, and how then do we articulate what is within the realm of a municipality's responsibility, what is our collective responsibility, and our ability to actually, shift the dynamic when we've had particular neighborhoods that have been faring poorly as it relates to the Code Red reports over time and not seeing population health impacts change. In fact, in some cases, things getting worse. And recognizing that there's many reasons for the situation getting worse for our residents, everything from the housing crisis, everything from, an emergency of a toxic drug supply to the economic impacts of the pandemic, and then the, economic recovery or lack of recovery that is disproportionately impacting people. And then the climate piece on top of that, and whether or not our residents have equitable access to green space and healing spaces in nature. Multiple factors in play, but I think fundamentally from a municipal lens perspective, for me, it's both from a public health committee member, but also from a what does effective city building mean, and how can it play a role in supporting the work that you're outlining here today. Thank you for the presentation. Thank you.
Thank you, Ministry of Housing and Health, and then you can have a Ministry of Market over there. Okay, thank you. Councillor Alex Wilson, please.
Thank you, and through you, Chair Wilson, really again echoing colleagues and appreciative of this presentation, kind of this update on how we've been responding since 2018 and getting ready to go. One of the pieces here that I'm noticing, though, is this is how we're innovating within the system. There are capacity concerns, and this is how we can work together to find those innovations, those collaborations, those partnerships that maybe use fixed amount of resources better to get a different outcome. To what extent is that possible? Because I know that there was goals set. So for example, getting everyone a family care physician. Is that something that we can partnership our way out of or make new connections to get there? Or do we just need more doctors? And so the bit I think I'm seeing the smile there, but I think the bit I'm trying to get to is there's two things that affect our goals: how we innovate and all the amazing work going on here, but also the raw funding envelope. Could you speak a little bit about where the efforts that you're trying to do will not be enough, maybe?
Thank you.
1000%. It's not enough. No, we are not even graduating enough family doctors to take on, what the community needs. So I'll say that it's both. It's both trying to reorganize to find the capacity within, but it is second advocating for the resources that our community deserves. And that's why on Friday we'll hand in the most massive primary care proposal to the ministry we've ever written. And we're writing that together as one entire community. So what I will say is that, I think that we will be successful in advocating for funding by showing this partnership. That, Healthy and Safe Communities isn't putting a proposal for this and I'm putting in for one. We're doing this together so that we are actually mapping the vision for our healthier community together. Really proud that at the end of this week, we will hand in that proposal that includes, 7 family health teams, 4 CHCs, community providers, shelter health, everyone signing on to a vision that better primary care for all is important to us. And I think that shows our readiness and our determination that we're really quite serious about working together. But it's going to be both. We need to look at how we can reorganize to make sure that we're maximizing the things that we have. But I'm not, naive. We have a human health resource shortage and crisis in healthcare right now, in many sectors. We can't find enough nurses, PSWs to do the work. So, that in itself is a huge risk. So we have to continue to advocate. I just want to be doing that as a whole system of partners and not individual sectors alone.
Thank you very much through the chair. Really appreciate that answer. And I think it really helps explore again, because we'll be getting these updates annually. And so one of the things that I really appreciate in this is it talked about all the skilling up that we're doing, all of the capacity building. And then I think in future updates, I'd love to hear how that compares with the system capacity and get those areas of need. It seems like a surprise to no one. Like, I've been on the Ontario Connects for the Waterloo region to get a primary care physician back when I used to live in Waterloo several years ago, and still have not been placed despite being on that wait list. I have a family care physician in Hamilton after almost a decade in the city. They're on the complete geographic other side of the city. And so I think we know that those are problems. People in this room understand that those are problems. Are there other areas that just system capacity is so far gone? I think of home care, for example. We saw a report about 2 years ago now that said almost 1 in 2 families could not get the home care they needed. And I think that was, again, about 2 years ago now. I can't imagine the system's resolved itself. Do we know what some of those other crunch points are? Home care, primary physicians?
Oh, absolutely. An aging population and not enough home care is, trouble. So there isn't enough home care. You'll see that patients are waiting in hospital and they are to be discharged but can't because they can't find those home care resources. Oftentimes, patients are sitting in hospital because there's not an alternate level of destination for them to go to. So there's not enough long-term care home beds. There's not enough community spaces with support. So, I would say the overarching, real complex problem we all share is housing with supports. We need supportive housing. We don't have anywhere to discharge, complex mental health and addictions, complex seniors. If we want people to age in place, and live healthy in their home, we're going to need to provide supportive housing. And there isn't enough investment in that. And we need more support with that for sure. Not only to clear up the hospitals, but to improve the quality of life. Nobody wants to live in a hospital, right? That's not, a desired destination for most. But yes, PSWs, nurses, across all sectors, we're really suffering that way. And we need to ensure that we're not only retaining, but we're recruiting. We have amazing medical and nursing school right here in this city. What are we doing to make sure that those people stay here because they love working for Hamilton? So I think that those are important, pressure points for all of us. I could probably go on about all the challenges, but I would say that those are probably some of the biggest. I would also just say a quick note about digital. Digital is complex too. We don't have a connected medical record. Physicians in one office don't have the same as the physicians upstairs. So we've created a very, deeply complex matrix of digital supports that don't all talk to each other. But we also know that when care providers can talk to each other about one patient, that circle of care is better. It's better for the patient, it's better for the providers, but we're not always there yet either. So that will also need infrastructure and funding support to move forward.
Again, thank you. And through the chair, really appreciate that clarity. And then in future updates, would just love to hear that tension point of here's what we're trying to do, but we're not going to meet our goal until this funding gap has been identified. So we as decision makers better understand what we're doing and where we're meeting that, and then what we're doing and where without additional advocacy, those additional grants, we won't make it. I think a very technical final question for me is just, do we have the Board of Governors filled out for the Greater Hamilton Health Network? Are there currently vacancies? I just note that the number talked about in the appendix is not the same as the folks listed on the website. So just wondering if some people aren't public board members or what that discrepancy is.
Yeah, before I answer that, I just want to say too, I think that we should probably think about how to get to a point where we ask for funding as one system, and maybe the OHT is that, so that we can use all of our local knowledge and expertise and data to inform where resources need to go instead of leaving that to, siloed individual organizations. The board of directors will bring on 3 new members this month. There will be 3 new members that will have to join in the fall. So we aren't full yet, but by fall of this year, we'll have the full 18-member board.
And sorry, very final question from me through you, Chair, is do we know what sectors are not currently represented through those 3? Are those some of the duplicate sectors, or do we know if there's specific expertise or parts of our healthcare system that are going to be joining this year?
Yeah, so home care is still open. And that is also because the Ministry of Health hasn't fully determined how home care will fit into the OHT model yet, so we've left that one open, and there's 2 community seats that are open.
Thank you.
Thank you, Councillor. Councillor Clark.
Thank you, Chair, and I sincerely appreciate the candor that we've had this morning. It's rather refreshing, so thank you. Can I ask, Chair, who appoints the members to the board? Is it the board themselves?
Thank you.
Yeah, we have a governance and nominating committee as part of our board of directors, and under our bylaws and governance manual, they help interview and understand the sector representatives. They bring a motion forward to the board.
And is the appointment to the board chair ratified by the province, or is it the sole control of the GHHN?
It's the GHHN.
Thank you. Can I ask, the map you showed indicated northwest Niagara. So that is a part of our team?
Grimsby.
Yes, Niagara Northwest, so Lincoln, Smithville, Beamsville, and Grimsby.
And do they have a position on the board?
There is one board seat that we've held for our rural partners, Haldimand and Niagara Northwest, and we do have a member from that region, yeah.
So we have a membership from Haldimand, but not from Niagara.
Well, technically, West Lincoln Hospital is a Hamilton Health Sciences location, so we do have Hamilton Health Sciences on our board. But no, we don't have a specific Niagara Northwest practitioner, so they're more represented from the hospital side at this point.
Thank you.
I don't want to speak for Niagara, but it would seem that that community needs to have representation on the board also. Mental health. I listen carefully. One of the challenges that I've seen, at least in my ward, is the inability to get psychiatric intervention for someone who's experiencing a crisis, especially young people. So how do we fix that?
Yes, complex. Right now, the GHHN focuses on adult mental health and addictions for right now. Linwood Charlton being the lead agency for children's mental health, they collaborate with the children's serving sector at this moment. It for sure is an issue. We're working with St. Joe's to understand how to expand psychiatry, into the community. Also, too, Ontario Structured Psychotherapy has rolled out in the last year for GHHN, which includes, low barrier way of contacting, psychotherapy virtually. But it's an ongoing complex issue. Right now, under the Mental Health and Addiction Secretariat of the GHHN, we focus on a few things. Integrated care for those who have schizophrenia, looking at expanding Ontario structured psychotherapy, and looking at safe supply and harm reduction approaches and expanding those across the GHHN. Those right now are our 3 key focuses. But we do have a full adults mental health and addiction secretariat under the OHT, and they meet to develop and collaborate on local initiatives for mental health and addictions.
Thank you, Councillor.
It's frustrating because I have been hearing for years about the need for increase in funding and services for young people with mental health needs, but I'm not seeing any change. So how do we deal with that? How do I respond to the resident who called me a couple years ago and advised me that she tried desperately to get her son in to see a psychiatrist? Unfortunately, that didn't end well because it never happened. I'm hearing of 2-year waits for young people to see a psychiatrist, and yet it's not a priority of our health network. I don't understand who looks after it then.
Yeah, I would say it's not that it's not a priority. We thought that as a system organizer, because our community has a lead agency for children's mental health, that planning and strategy would run through that system while we focus our resources on the adult sector. So I can't comment for how Linwood is working right now. With our resources and our 7 staff, we've had to focus. We've had to narrow down the focus. There's a lot of complex problems in mental health and addictions, as you know. So we focused on the adult system for right now.
Mm-hmm. Thank you. Councillor?
Yeah, that's not, I think I'll like to be put down for comments afterwards. I'm very frustrated that we are not, and I say the collective we, which would include the province, doing even a reasonable job in providing mental health care for our young people. And that is, it really bothers me. It bothers me that the priority is adult mental health. I get that, but the priority should be mental health. And to have all these young people, where do we go? And we can't dump it on Linwood because that's unfair. They provide care to one subset. We have a much larger problem in the city of Hamilton. COVID made it much worse, and people still don't. Where do they send their young people? They're not getting help, Chair, so I'm frustrated by that. The last question I would ask then, who holds the GHHN to account? Who does the GHHN work for?
Yeah, I'm held accountable by the Ministry of Health and Ontario Health jointly.
Thank you.
Thank you. GM Burden, my apologies as I didn't see your hand. Did you wish to add anything? Thank you.
Thank you. Through the chair to the councillors, I wanted to add a bit of context in terms of the Ontario Health Network concepts provincially. It's really the ministry's attempt to look at population health planning and collaboration across the whole constellation of organizations funded by the Ministry of Health. You could call it the coalition of the willing in terms of, from an accountability perspective, as I mentioned, around the patient care and the risk and the accountability for patients are really outside of the collaborative agreement signed by the Ontario Health teams. In that vein, every year, the Ministry of Health provides through Ontario Health the priorities that the Ontario Health Networks are funded for. And sometimes the priorities that we receive funding for are not necessarily the local priorities that we have. And I would say that mental health is one of those where the Greater Hamilton Health Network has actually gone above and beyond what they are funded for in order to respond to the felt need of mental health and addictions within the local community. But one of the conversations that we've had at the executive committee is we don't have a lot of say in terms of determining how the GIN is funded, in terms of saying these are the priorities that we need resources for. So I would, back to Melissa's point around 7 staff, many times those staff are attached to projects and initiatives that the ministry has said are going to be rolled out provincially. Mental health has been one of those areas where I would say Melissa and her team have rallied all of the providers to say we need to go above and beyond those expectations. And I also want to acknowledge a lot of the, there's a sense in which the Ontario Health team in Hamilton is advanced in terms of the work that is being done. And I think that speaks to the commitment of the partners around the table in absence of sufficient resources to do as much as we can in a collaborative way. I think I just want to caution council that the GIN does not have the umbrella accountability for how the health system is functioning or is funded for the Hamilton partners as we go forward. Thank you.
Thank you, GM Burden. I recognize Councillor McMeekin.
Thanks very much, Madam Chair. First of all, my apologies for being late. I had hoped to plug in virtually, but I was having technical problems with my internet. So sorry I missed the first part of your presentation, but I'm very happy to have caught what I caught. I have a very practical question. I'm familiar with the Ontario Health teams, having been connected with a family doctor for many years, and some of the struggles there. And I know that these health teams, GM Burton, I think, is alluding to some of this, have sort of visions of where they need to go. They enter into contracts with the province around the personnel matrix that needs to be there and the priorities. There are communities, and my Waterdown community, I think, is one of those where retirements set off a whole new dynamic. You get a couple of family doctors retiring from a family health team with the provincial government insisting the positions be filled in seemingly a vacuum where there are difficulties attracting and retaining family physicians. What's the best advice you could give to a family health team that hypothetically might be located in Waterdown, who's got that kind of a struggle and is looking for, at some risk to the clinic, the acquisition of a couple of additional family health positions?
Yeah, and I appreciate that struggle's duplicated across all of our regions right now, for sure. I'm not sure if you heard, but we actually just started to receive, really accurate mapping data of where all of our physicians are and their impending retirements, which is actually really helpful for us to plan as a system about where that's coming up. And part of that work is being done by the physician recruiter that now is part of the GHHN staff. We're not going to graduate enough, family physicians to cover this loss. What we do need to do is expand the team around family physicians. Many parts of the health system can be dealt with other interprofessional members of the team. There's nurse practitioner-led models, social workers. So that's actually a big part of the proposal that we're handing into the ministry this week, is to expand the team around primary care so that, number one, they can take some stuff off the plate, and number two, that they could have capacity to bring in new patients if they practice in a team model. That team model has been highly successful, to ensuring that not only the patients have comprehensive care, but that physicians can decrease their admin workload, cut down on some of the added stuff that they've been doing as physicians, and then hand that off to a team member. So very much, thinking about, in this crisis right now that we have about family physicians, understanding the interprofessional team that we could wrap around them, to ensure that we can't do much about retirements. The last few years have been extremely stressful in the family practice, situation, but to ensure that we're constantly out there recruiting. And again, we have an amazing medical school here right in town. How are we going to retain those practitioners to stay here in Hamilton? Our physician recruiter is, a really important part of that. But then also showing them, this Ontario Health team has developed a huge primary care network. You're part of something if you sign on to primary care here in Hamilton, and that's important. We want them to feel connected, part of strategic planning, and that's why we've made primary care, at the center of our OHT as well, because we know that we won't be successful if no one in Hamilton has a primary care medical home. So I would say there's multiple strategies that have to be looked at in terms of physician recruitment and retention.
And thank you, through the chair. Hamilton's very much taken the lead in terms of family health teams over the last several decades. I know some of that's related to our excellent medical school and some predictable retention where possible. So let me, you got to deal with the cards you've been dealt, not the ones you wish you had. Let me cut to the quick here. Are you optimistic that the plan you're presenting on Friday is going to bear fruit in terms of the new enlightened team approach that you're talking about, Melissa?
The provincial government has dedicated $30 million over 2 years to expand team-based care. We need that alone here. So I'm not, not optimistic we're going to get the full, but we know that there's going to be some federal investment into primary care, and we want to show the ministry that we're ready because we've mapped out what the vision of need for our community is. So incrementally, we're hoping to expand those team-based resources, year after year, with hopefully not only investment, but understanding how to expand the current capacity of primary care in the community. And I think that we're in a really good stage to understand what each organization has to offer, because we have, collated the whole entire primary care sector together as one for the first time. They've very much planned in siloed ways, clinics over here, family health teams over here, but now we've actually have one place where we do that planning together, which is great. So no, I don't think I'm gonna get 30 million, but I'm hoping the ministry understands this is what it's going to take to serve the patients that live here. And incrementally, we'll start with those that are most hard to serve, and those that need our care the most. We have a phased approach for rolling out any funding that would come into Hamilton.
Councillor McMeekin.
Thank you, through the chair. I really appreciate your leadership on this. I understand painfully, I understand the challenges and the complexity of it. It's interesting that decades after struggles with e-health issues and talking to each other, that continues to be one of the major challenges of the healthcare system. So, but thank you so much, and good luck. I really, I'm an incurable optimist. I suspect you are too, so we'll keep our fingers crossed. Thanks so much.
Thank you, Councillor. Up next is Councillor Pauls, followed by Mayor Horvath and Councillor Wang for a second time. Councillor Pauls.
Thank you. You talk about primary care and all that, and how to serve our patients, and thinking about the mental health and the addiction problem we have. Is in your approach education as well, where we can tell them the danger of drugs and addiction or whatever? Is that part of the primary care education? And do you have an education part?
Presenter McCallum.
Absolutely. I think that, part of the team-based proposal that we're even putting in is the extension of mental health counselors for all, including youth and adults. And I should have mentioned that before. So, we know that those that are, being seen by primary care offices, need to be supported from a mental health lens. I'll say that we're starting some education. We started in May as being kind of a harm reduction focused month. We had several webinars that, leaned into education about harm reduction philosophies and drug use and addiction care. We do that for the public, and we did that for medical practitioners. But as we move forward, it's all part of, a phased approach, not looking at just clinical delivery, but you're right, Councillor Pauls, looking at education and how we, work with partners like public health to get education out, reduce stigma, and understand from a public lens, what our communities need to learn about mental health and addictions, because it is quite complex. So we do look forward to working through more education opportunities.
Thank you. Councillor?
I think education is the most important thing. When my 4 boys, I always thought, stay away from drugs. And I just don't understand when I hear words safe drugs. I don't understand it, because there's nothing safe about drugs, nothing. So education, in my point of view, is the most important, and take responsibility in trying to help. And also, what I notice is places where people can get help to get off drugs. How many do we have here in Hamilton? I know of Wayside, which is a great organization. It's fabulous, but they have a waiting list. When are we going to take that on, where people can really get help, with supportive help, to get off drugs, to help their mental health? That's what we need to focus on. We really do. It just breaks my heart.
Question, Councillor.
So my question is, are we looking at more places where we can have rehab places where the people can recover? Are there places like that? How many do we have here in Hamilton? And
Thank you. Presenter McCallum or Dr. Richardson, beg your pardon.
Through you, Madam Chair. So when we look at issues of mental health and addictions, particularly addictions as we're speaking to right now, we know we need a comprehensive approach. It needs to include education, it needs to include prevention initiatives, but it also needs to include treatment, it needs to include harm reduction, it needs to include housing initiatives as well. And so all of those things are very important in order to move the needle when it comes to addictions. When we're talking particularly about treatment services, you'll see in the Hamilton Opioid Action Plan, which we're going to present next, that is one of the areas, along with education, youth prevention initiatives, that we feel needs further investment, particularly when we're talking about supportive housing. And Melissa's spoken to this, Angie's spoken to this. We have long meetings about this around supportive housing. And what does it mean? You know, absolutely additional supportive housing to help those with mental health issues, to help those with addictions issues is required as well. So you'll hear more about that, you know, treatment, the amount of resources that are needed as we work through the opioid action plan.
Thank you, Dr. Richardson. Councillor Pauls.
And thank you for that. And I think we need to push that the most. Get places where people can go and get recovery, because that's the only way out, I believe. We need more places like that with supportive housing. And we need to make sure education is number one. When you educate people, that's when they learn the harm of drugs. So thank you for that, and thank you for your presentation.
Thank you. Mayor Horvath.
Thanks very much for a really great presentation and really good discussion around the table. There's just 2 or 3 things I wanted to ask about. One is, as we talk about physician recruitment and the need to keep healthcare providers here, as we have such a great university that provides excellent education in all sectors of the healthcare system in terms of training and degrees. To what extent do we look to expansion of things like nurse practitioner-led clinics, CHCs, that model? I know my experience in the past has been that where there are real difficulties in physician recruitment, particularly I think of Northern Ontario, one of the ways that the population gets access to primary care is through nurse practitioner-led clinics or CHCs, community health centers, whatever we want to call them. But it seems to me that's something that's perhaps a model. I know we have a couple of them here. Could you speak to that a little bit?
Yeah, absolutely. And our expression of interest for expanding primary care will revolve around those roles exactly, because we know that they're highly effective to not only giving patients, you know, extensive primary care, but that team model. So I'll say the vision, you know, for primary care here in the city is that all physicians will have access to a team, that they will be able to refer, you know, patients that need to see a mental health worker, a dietitian, into a hub that provides team-based care. The current landscape right now is that there's physicians that practice solely on their own. They carry a roster of 2,000 patients, and they have no access to anyone else to help them through the day, to help with complex issues. So really the vision is around expanding that team for every single primary care physician in this city, and that will include utilizing NPs to their full potential. We're not going to be getting more physician dollars. What we will be getting is dollars for expanding, you know, those interprofessional health teams. Co-location is another big thing. We're looking at how physicians can come together under the same roof so that we can also wrap that team of health and social care around them, you know, better logistically, so they're not off practicing, you know, alone. We actually don't have a nurse practitioner-led clinic on its own here in Hamilton, but part of what we're building is that incorporating NPs into all of these models to help the physician workload for sure.
Excellent. Thank you.
Okay, thank you very much for that. I wanted to follow up a little bit on Councillor Clark's identification of the gaps in mental health services for children, and this is a province-wide problem. We have a real serious problem when it comes to access to mental health services for children. And I know that that's not something necessarily that you can address right here and now, but I wouldn't mind working with Councillor Clark and others who are interested around this table to look at how we can amplify that need, because, you know, I think about having been in different communities that, for example, we're trying to cite a consumption and treatment site, and the conversation, the public town hall conversations were often about young people and their stories. So it wasn't people talking about young people, it was young people telling their stories about how they ended up in a situation where they became addicted to drugs. And oftentimes it was unresolved trauma. Well, if we know that unresolved trauma leads to self-medication in some cases, isn't it then our responsibility to make sure that we help people resolve their trauma early? And not end up in a mental health crisis or worse, as Councillor Clark identified in the tragic scenario that he shared with us. And so I think as a community and as a public health body, we really need to be thoughtful about that, because it's really troubling that we have these kinds of holes, if you will, in our system that then just lead to very, very bad outcomes for kids, for young people, and for adults as well. But certainly the huge gap is one that I think we need to take seriously.
And expensive outcomes.
I just wanted to say there is a planning body for children's mental health in this city. There isn't. I don't have project management around it just based on capacity, but there is a current, standing, cross-sectoral planning body that looks at children's mental health. And the reason why I mentioned Linwood Charlton is because they are funded to be the lead agency and planner for youth mental health in the city. So there was just a bit of distinction. So I just wanted to mention that as back to Councillor Clark's comment.
Thank you. That's all. Thank you.
Thank you. Looking around the horseshoe, any other comments or questions? Councillor Tattison.
Can you just highlight the work that you're doing with the boards of education around children's health?
So children's health is planned at the other planning body in the city.
Okay.
So yeah, like I don't have project management. I don't sit at that planning body right now. I'm focusing attention on adults' mental health and addiction issues right now. And that's just based on capacity, not because of no desire to.
Through you, Madam Chair. So this is one of the challenges, is that the system, as integrated as it is through the OHT, is not yet fully integrated, and it's challenging to do. But I wondered whether it would be helpful, because we are doing a lot of work with the boards of head through public health in looking at children's mental health, and children's mental health in particular is a focus for that work. So I know Jen Vickers-Manson is online. She's been at meetings in Toronto today, but she was able to join us. I'm just going to ask Jen, do you want to add anything about the work being done, either from a systems perspective around children's health planning or specifically related to the boards of ed?
Thanks, Dr. Richardson. Through the chair, can you hear me?
Yes, thank you.
That's great. So I won't add anything more to what Melissa has talked about around Linwood Charlton Hall being the lead agency for planning the children's mental health services in our community. And just to be really clear and building on Councillor Paul's comments and Elizabeth's comments on the requirement for a comprehensive approach from prevention to treatment. So Linwood, as an example, as the lead service provider, is really focused on the treatment end of the spectrum. And I'll just remind Health Committee that our school program has nurses that are linked in schools and work along at multiple levels with our school board partners. And that includes sitting down with the directors and the senior leadership team to identify what the main priority issues are that we're going to collaborate on together. And for the last number of years, the focus has been around mental health in our children and youth. And so what that means is that our nurses are working at the school level with principals. They share data to talk about what the issues are, and then they work in collaboration with students, parents, and adult allies that come in the form of teachers as well as community members to plan meaningful engagement sessions to impact peers. So this often looks like peer-to-peer education sessions, peers doing events in the school for youth focused around changing and creating a supportive culture in schools, and as well as linking to critical resources in our community. So I appreciate that's really high level. But we do have, I just do want to highlight that we are working with our school board partners at multiple levels in ways that are meaningful for youth in a co-design model.
Thank you very much. Thank you. I don't have any further speakers. I'd like to thank Dr. Richardson. To Executive Director McCallum, you are our guest. And on behalf of this committee, I want to thank you for the richness of your presentation, the frankness of your answers. And I know there are a few of us who will like to pursue a conversation with you about experiences in our neighborhoods and, in our opinion, the importance of coterminous in design and neighborhood in delivery. So thank you very much. If I could have a mover and a seconder to receive the presentation, moved by Councillor Taddison, seconded by Mayor Horvath. Yeah. Sorry, thumbs up for me. Thank you. That carries 14 to nothing on the report. If I can have a mover and a seconder to put it on the floor. Moved by Councillor Wang, seconded by Councillor Alex Wilson. Any questions on the report? I recognize Councillor Wang.
Thank you. Through you, Chair, to either Dr. Richardson or to, I think we can still ask Melissa McCallum if she's still available to answer. But where are we at with the new physician retention program? Because it was transferred from the City of Hamilton to the GHHN. And what's the status look? Has it been fully integrated? Have we really gotten it started? And what does that look like today?
Thank you, Councillor. Oops, beg your pardon. Executive Director.
Yes, so the staff member has been fully integrated into the GHHN team. So that's been finalized, and he's working away at understanding how to integrate with our primary care network. He's been leading all the mapping work with our physicians, which has been incredible. We are just finalizing the last transfer agreement, and then everything should be done in the next 2 weeks, actually. So I think it's an excellent addition to our team, especially as we look at, retirements and retention planning for the future. So support it. Thank you to Council for supporting that decision.
Councillor.
Follow-up question then. I recently received a delegation from almost 60 Chinese seniors who were highly concerned about the loss of their staff resource person, as well as identified that there are very few, if not none, Chinese doctors that could speak the language, because as we know, this is a health equity issue, because if you cannot speak English in a fluent manner, understanding something as complex as medical concerns is going to be very harmful and very traumatic to especially those that are in senior sort of age brackets. So I wonder, could I put a bug in potentially executive director's ear about the increased need to look at delivery of services in different languages for physician recruitment? Through you, Chair.
Do you have that bug? Executive Director.
Absolutely. Language accessibility is actually one of our 4 key priorities under our health equity work. We need to ensure that wherever someone enters the system, they're able to understand in their own language, and that we don't want to depend on caregivers to be doing that. So 100%, obviously cannot promise the recruitment of, primary care physicians that speak those languages, but what are other ways and other technologies that we are going to bridge that gap so that we ensure people are getting, culturally and linguistically safe, delivery of services. So absolutely.
Last question through you, Chair, is I wonder where the scope of the physician recruitment director could feasibly look at specifically internationally trained nurses, for example. We absolutely have a lack in terms of nursing staff, but does that also include those sort of interconnected or potential relationships with building up? How do we bring in more internationally trained staff and nurses like doctors to the network?
Thank you. Executive Director?
Yeah, so right now the position will focus on just primary care recruitment because it's so extensive right now, but we've already talked about how to build out an actual OHT recruitment and retention arm in partnership with the college and universities that we have here, because we have those amazing assets. So more to come on that, but right now the position will be focused on primary care.
Thank you. Those are all my questions.
Thank you, Councillor. Councillor Clark.
Thank you, Chair. So can I ask, the City of Hamilton was a partner to the Physician Recruitment Retention Program, and of course we were the administrator here at the city. So is the funding agreement that existed between the numerous bodies, is that going to continue?
Dr. Richardson?
Through the chair. So the arrangement actually with the physician, Hamilton Physician Program was complex in terms of there being a number of parties that were supporting that program. It was largely administered actually out of the Chamber of Commerce, and each partner had roles to support it, and one of them was funding. So the transition of that funding arrangement has been made, and as Melissa's just described, the city itself has transitioned its funding over, and we held the funds. We did that role in that partnership, and those funds are just now being transferred over, the ones to support ongoing recruitment. And then Melissa's been working with each of the other parties to develop individual agreements with each of those parties to support the program. I don't know, Melissa, if you want to explain that a little further.
Yeah, it's a unique program where a variety of organizations were paying into this role. So those organizations will continue to make that yearly payment to retain the physician recruitment piece.
Thank you. Councillor.
Chair, can I clarify more for the public than for myself? The surplus of $515,000 some odd dollars, that was not Hamilton's money, that we were simply holding that money for the collective. Is that not correct?
Dr. Richardson, are you able to confirm?
Through you, Madam Chair. So we were holding the funds that had come from the different partners for the program to support the physician recruitment initiatives. And so when it was decided that the program would be transferred, we went back to the partners to ask them, how they wanted to move forward in terms of the funding. And then transitioned. There's still some issues to be wrapped up with the program, so we continue to hold some of those funds with the city. And then the funding partners' contributions were moved over as per the directions of those partners to the GHHN, and then the ongoing funding was established, as Melissa's pointed out.
Thank you for that clarification.
Thank you, Councillor. Beg your pardon, no further speakers or questions. The report has been duly moved and seconded by Councillor Wang and Councillor Alex Wilson. It's up for your consideration, please. Councillor Taddison? Thank you. That carries 13-0. We're on to item 8.2, Hamilton Opioid Action Plan, BOH 23021. Joining us, I have Dr. Richardson on the roster again, and Melissa Bixa, Manager of Mental Health and Harm Reduction, to present.
Through you, Madam Chair. So I'll just give a brief introduction and then turn it over to Melissa and to Mark. So you'll recall that as we went through the early part of the year, there was a lot of discussion about harm reduction, opioids, and the toxic drug supply, and a lot of interest in moving forward in new ways. You've heard from Melissa McCallum already. There's been ongoing work with primary care and others that are being driven through the GHHN as well. And so we're very much doing this work in partnership across all of the agencies that are involved through the Drug Strategy Steering Committee. The group was brought together, and you'll hear how it's evolved to develop an action plan and come forward with a number of recommendations for your consideration. Melissa, of course, is our program manager who's responsible for this area, and Mark Kasha is a public health and preventive medicine resident who's been working with us this past 3 months, and he's going to start off the presentation, and then Melissa will take you through the remainder. So I'll turn it over to Mark.
Great. Thank you so much, Dr. Hurston. And good morning, Council. Thank you for allowing us to present today. So a brief outline. The first half will go over some local context, and then the second half will dig into the Hamilton Opioid Action Plan, or HOPE, and kind of the process and the recommendations that have stemmed from it. So the first part fulfills Council's ask for quarterly reporting on opioid-related data. So the first slide we have here is our opioid-related paramedic calls from our colleagues at Hamilton Public Health Services. So as you can see, for the first quarter of 2023, so January to April, we've had 336 calls, which has been more than the preceding quarter from September to December, as well as the same quarter from 2022 and 2021. And so most of these calls have occurred in Ward 2 and Ward 3, but they've occurred all across the city. The second slide is from the Chief Coroner's Office, and it's suspect-related deaths in Hamilton, again broken up by quarter. So you can see the first quarter of this year, there's been less suspect-related, drug-related deaths compared to the preceding quarter, and as well as the same quarter from 2022 and 2021. There's a couple notes with this data. It is preliminary, so it's subject to change as the cases become confirmed, and it is location-based, so this doesn't necessarily mean the deaths have occurred in all Hamiltonian residents. And finally, this is for all suspect drug-related deaths, not just specific to opioids, but this is useful as an early trend indicator. And then, one more note. The decrease in the first quarter is something that's being seen across the province and not just in Hamilton. And so we're currently unsure what's driving this downward trend. Finally, our great colleagues in epidemiology have broken it up by forward sortation area for Hamilton, which is the first 3 identifiers of the postal code. So the forward sortation area, or FSA, shows that most of these suspect drug-related deaths have been occurring in L8L and L8P. L8L predominantly overlaps with Ward 3 and to a lesser extent Ward 2, where L8P is wards 1 and 2. And so any FSAs that have had less than 5% have been collapsed into the other column at the end. And if there was less than 5 suspect-related deaths, those were suppressed from the overall numbers. And the other important note for this slide is that most of these suspect drug-related deaths are occurring in private residences at 73%, followed by congregate living and outdoors at approximately 9% each. And so this local context is really important to frame the development of the Hamilton Opioid Action Plan, or HOPE. And as a brief backgrounder, we were directed by Council in February 23 to create an evidence-informed harm reduction plan. And in parallel, the Hamilton Drug Strategy also identified opioids as one of their priority action areas. In March 2023, we contracted Mass LBP, who I believe are on the line, and they facilitated some great consultations with our community. And underscoring the importance of this work, a triple emergency was declared in April 2023. And so HOPE really provides the immediate medium and long-term operational guidance to help address this crisis. And here we can see just the consultation broken out a bit more. It happened from March to May, and there was numerous meetings with partners, internal leaders as well, and there was various checkpoints to confirm the themes and the overall direction of the plan. And I'll turn it over to Melissa to take us through the actual details.
Thanks so much, Mark. So at the outside of the development of the action plan, 3 main objectives to achieve through the plan were established. 1 was to reduce the number of deaths associated with opioids. 2 was to reduce the harms associated with opioid use. And 3 was to increase access to a spectrum of treatment options. Through the establishment of these objectives, HOPE also set out and said to achieve these goals, the steering committee would work in the following ways. Through the action plan, to provide a mix of both short and long-term actions to implement, to establish recommendations that are both tangible and actionable in our community, to improve data collection and evaluation, as well as enhance collaboration across the spectrum. Mark briefly highlighted this in the overview, but over a 4-week period, our colleagues from Mass LBP conducted 33 interviews and focus groups with members of both the Hamilton Drug Strategy Steering Committee, as well as other community members and organizations to really understand the impact of the drug toxicity crisis and to gather information on how to begin to pull and move this action plan forward. Throughout the development process, a snowball sampling approach was encouraged, meaning that members of the steering committee and other community members who participated in the conversations were also encouraged to recommend other community members, people and persons with lived experience, equity-deserving groups, and health and social service providers to consult. All participants who participated in an interview prior to their interview were given 3 main kickoff questions to think and consider, and also to talk with colleagues and clients to help and consider the evidence base. This was really, we asked them, what is the impact of the opioid crisis on your community or sector that might not be widely understood? What should the plan try to achieve? And what are 3 or 4 actions you believe in that should be taken in the short, medium, and long term to decrease the harms associated with opioid use? We are incredibly grateful for the contributions of the community members over this consultation period. These community conversations were essential in continuing to drive the action plan towards the recommendations that we presented today. From early on, a number of themes consistently emerged from our community members. Some of the things we heard is that this crisis is deepening and requires focus and leadership. That poverty, inadequate housing, overstretched shelter services are exacerbating the crisis here in our community. That limited coordination between service providers is reducing the collective impact that we're able to have. There is a strong feeling that we can get our hands around this if we concentrate those most at risk. We need to address the public stigma associated with substance use in our community. We need, as a collective, to show results. We need to hear from each other, even when advocating for different approaches and treatment modalities. Families in our communities need support. Primary care providers need support. Our frontline workers, as was discussed in the previous presentation, are struggling and burning out as well. Empathy, community, and skill building are keys to meaningful recovery. These initial themes that emerged from our community conversations were brought forward to the steering committee in a meeting in early May, where they were reviewed. And from that meeting, a number of early recommendations were decided upon. Draft recommendations were then developed by our team and then sent out to the steering committee, members who participated in the community conversation, for further review and feedback. A survey was also circulated, and steering committee members were also encouraged to share amongst their networks for further feedback. Our survey results showed that there was strong support for the proposed action, between 68 and 89% of respondents indicating that they strongly agreed or agreed with each of the action plans. So as we move forward, the action plan that's being presented here today presents immediate, medium, and long-term recommendations for the coordination of local action here in Hamilton. It's important to note that these present immediate actions are needed to address the crisis where we are today, to stop and reduce the harms and deaths in the short term, while continuing to address the broader social and systemic issues further exacerbating this crisis in our community. Throughout the consultation period, participants clearly articulated the need for this action plan to be bold and to present recommendations for immediate action. The plan that we'll speak of about in the slides to come provide 13 recommendations that are evidence-informed, feasible, and will help to achieve the established goals here in Hamilton. And looking at the immediate actions that have been outlined in this plan, immediate actions are those which will be initiated within the next 6 months. These include establishing an opioid action table to oversee implementation and to be accountable for the overall Hamilton Opioid Action Plan. 2 is to scale up supervised consumption sites across Hamilton with a particular focus on providing areas for supervised consumption in men's shelters and through the establishment of a mobile site. Developing safer use policies in hospitals and care settings. Increasing the availability of drug checking services and resources to support harm reduction and increase our local surveillance on the unregulated and toxic drug supply, as well as continued engagement and support for primary care providers. Medium-term actions are those that are proposed to be initiated within 6 to 12 months' time. For these actions, it's clarifying service pathways and options for individuals who use substances, developing and implementing new youth prevention programs supported by persons who with lived experience and focusing on reach to younger ages with evidence-informed and age-appropriate strategies. To expand supports available to families, including supports for children of persons who use substances, and supports for additional services for families on how to support loved ones and those who are experiencing loss and grief due to drug poisonings. And finally, increasing access and support to shelters and drop-ins, including additional abstinence-positive spaces and increasing funding to additional services. Longer-term actions are those that would be initiated within the next 12 months as part of the action plan, is to increase the number of physicians able to prescribe opioid agonist therapy or OAT therapy and safer supply programs here in the city through increased physician training and support and increased support to existing safer supply programs. Expanding the availability of stabilization service, such as increasing accessibility for existing RAM clinics, or which are rapid access addiction medicine clinics, as well as looking at youth-specific RAM clinic pathways. Increasing access to rapid detox and residential treatment programs by expanding availability of programs, reducing wait times, and ensuring clients are supported through their transition between detox, residential treatment, and further recovery. As well as finally developing additional supervised consumption sites throughout Hamilton and really looking at continued partnerships through community organizations, shelters, or hospital care settings. The actions that we proposed, the 13 actions I just went through, have been determined by consensus of the members of the steering committee. At committee today, there is a series of recommendations before committee with recommendations for next steps, including not only the endorsement of the plan, but recommendations for an investment at a municipal level to initiate 3 of the immediate actions I outlined earlier. The first recommendation around recommendation for municipal action is around establishing an opioid action table. This is a critical step for the table to ensure accountability and effective operationalizing of the plan, During the community conversations, we heard a desire for service providers in the community to work in a more cohesive and supportive manner, to work in a way that reduces competition for funding and ensuring ensuring a shared accountability for the actions that we've outlined in this plan. We also heard the need for focused attention, time, and commitment of resources in order for this plan to be successful. We heard very strongly the continued need for inclusion of people and persons with lived and living experience and equity-deserving groups in the further development and implementation of the plan. As such, the Opioid Action Table will be composed of persons with lived experience, health and social service leaders, and equity-deserving groups and other key partners outlined in the recruitment by the steering committee. From a governance perspective, the Action Table will report to the Hamilton Drug Strategy Steering Committee and will develop task-oriented working groups for each of the actions outlined in the action plan. These working groups will be responsible for developing goals, setting performance measurement goals, monitoring progress, and reporting back to the Action Table. Recommendation and implementation of the action plan is contingent on dedicated time and resourcing. And in order to be successful and work in an expedited manner, Public Health Services has recommended an increased staffing complement of 1.0 FTE for a health strategy specialist to support the planning and coordination of this action plan. Our second action consideration recommended at a municipal level is supervised consumption sites. For those not familiar, supervised consumption sites provide a place for individuals to use substances while in the presence of trained staff. Using in a supervised setting has been shown to reduce the risk of overdose and death and reduce the spread of bloodborne infections through the provision of safe consumption equipment. They also provide links to health and social services through the provision of wraparound services. During the development process, we heard from the community on the need to expand supervised consumption services in shelter settings. This also aligns with direction from this committee and council in February 2023 to consider how to implement safer use spaces and other evidence-based strategies, both within the city and houseless serving sector. Provision of supervised consumption sites in shelter-based services will continue to support people who use substances and reduce the harms associated from using in an unsupervised setting. Our recommendation before Council today is for Housing Services to initiate a request for applicants to provide a temporary 18-month on-site safer use space in a men's shelter. The funding request would provide one-time capital and operational funding for an 18-month pilot. Public Health Services would support a successful applicant with application to Health Canada for an urgent public health needs site and would also support an evaluation of the pilot with a report back to this committee. In addition to scaling to this specific request on scaling up within shelters, the action plan further speaks to further scaling up supervised consumption sites and exploration of a mobile model. Further planning and consultation will be done by the Opioid Action Table, and any subsequent funding requests would come forward as part of the 2024 municipal budget process. The final area that I'm going to speak to from the recommendations is the drug checking services. This recommendation seeks to increase the availability of drug checking services and resources within our community. Drug checking has been an emerging harm reduction approach as the drug toxicity crisis has continued to worsen. Drug checking allows for an analysis of an individual's drug supply. There's many different models in the community on how drug checking could be operationalized. In order to increase the availability of drug checking services and resources, the recommendation is for funding to support a one-year drug checking and surveillance pilot between October 2023 and September 2024. This funding would allow the Public Health Service to operationalize take-home drug checking strips, as well as the purchase of 2 point-of-care analysis units, which would be used to create a citywide surveillance system to better understand the composition of the drugs circulating in our community. As we wrap up our presentation today, in a high-level summary, this report brings forward recommendations to committee today on the following: is to endorse the opioid action plan as attached and amended today, to increase public health staff complement by 1.0 health strategy specialists to support planning and coordination of our action plan, to allocate funding for capital and operational costs to initiate a one-year drug checking surveillance system pilot from 2023 to September 2024, to allocate funding to housing services to execute a call for applicants to pilot a supervised consumption site for 18 months at a men's shelter, to direct Public Health Services to conduct an evaluation of the supervised consumption site and report back in Q4 2024, as well as authorize and direct our General Manager of Healthy and Safe Communities to execute and administer all necessary documents related to the recommendations put forward. As we look to move forward from the development of this action plan and following your consideration of the recommendations outlined in this report, the next step for this action plan is to establish the opioid action table as described, initiate the task-oriented working groups. This committee can anticipate that the next report back on the progress and associated performance measures would be in Q1 2024. And with that, I thank committee's time for today, and happy for myself, along with other public health colleagues, to take questions at this time.
Thank you very much to both of you and to your team for the work and the presentation. We have a number of councillors. I'll read them out so people know where they are on the list. Councillor Kretsch, Councillor Alex Wilson, Councillor Clark, Danko, Councillor Nan, Councillor Jackson, McMeekin. Councillor Kretsch, please.
Thank you, and thanks for the presentation. I want to just note right off the bat that there are postal codes you put at the bottom of the chart there are all from wards 1, 2, 3, and 4, about 82%. I wonder if you could comment on the effectiveness of the YWCA space. So it's at using a safer drug use space. They've talked about being able to reduce drug-related death in that space quite significantly. And so you talked about the fact that you see a downward trend. Could you attribute any of that downward trend to that?
Thank you. Melissa?
Yeah, thanks so much for the question. Through you, Madam Chair, to the councillor. So a couple points there. I would say I don't have any program statistics available from the YW that speaks to the number of clients served or overdoses prevented. Anecdotal feedback that we have heard from the operation and that was shared during the community consultation, councillor really does speak to how much it has assisted the shelter workers at the YW and staff from going to responding to a number of overdoses each week to now having a much more, to hardly ever, because of the use of and the availability of the space and the ability to support clients both accessing their services that are available overnight and coming in and out from the community. In terms of attributing it specifically to a specific site, we don't have anything specific that leads it directly to that. It can be a combination of interventions that we are continuing availability of supervised consumption spaces, provision of naloxone in the community that is cumulatively having an impact. As Mark noted, it is also a trend that we're observing provincially in this first quarter, and work that will continue to analyze as the year goes on.
Thank you, Manager Bixka. Councillor Critch.
Thanks. My second question is about the recommendations. You spoke to men's shelters and spoke to, making a potential pilot available in men's shelters. And I'm just mindful of that limitation. When I think of the examples of men's shelters in Ward 2, for instance, I can think of some spaces wouldn't really be able to accommodate that kind of space. I think of 3 shelters immediately, and one's actually going to be in Ward 3. And I think even in that new space, very difficult challenge. Would you consider opening this up if, based on need, or if you were finding applicants in the men's system, really only one person was able to come forward who could do this? I'm just worried about us not looking at this from the perspective of need or perspective of capacity, and then just ending up with kind of 1 or 2 applicants and having to choose from that. So just wondering if you can comment on that.
Dr. Richardson.
Through you, Madam Chair. So the current model that is put forward is a call for an applicant to come forward to do it as a pilot within that shelter system. So rather than looking to have to fund multiple pilots, that would be more expensive to do, is to have one of the shelters come forward, take us through a year of providing the service, look at what is needed, how does it run, what can we do, and then look at where we would go from there. So it would inherently be for a single provider, and then look at how to expand it following that.
So yes, I did understand that. That wasn't my question. I apologize. I'll phrase it differently. So I understand that there will only be one applicant in the end, but what I'm wondering is that there may be several people interested, or several shelters interested in becoming that applicant. By broadening it outside of just having men's shelters included, do you think that would be helpful in any way? I just want to get a comment on that, or comment why you're focusing specifically on men's shelters also.
Dr. Richardson.
Oh, right. Okay.
Oh.
Through you, Madam Chair, to the councillor. Again, understanding and what we heard from the consultation period, again, is the continued and expressed demonstrated need in the men's shelter system. So that is the priority area of focus that was determined, that was put forward by the committee. Again, the YW space serving female and female identifying individuals with that space currently available in our community. For this recommendation, it is a call specific to the men's shelter to continue to address the substance use that is currently being experienced within that sector in those settings.
Thank you. Councillor.
Thanks. My last question is, do you think you'll be able to find a shelter, or do you have one in mind that will be able to be this successful applicant from the men's system?
Through you, Madam Chair, to the councillor, no. Again, I think what we have heard from shelters providers is that establishing these services on their own is very resource. They don't have the financial resources to support this within their own operating budget. So supporting through provision of funding is our hope that would help assist one of the shelter providers in our community to bring this type of service within their facility. Oh,
thank you.
And over to
Councillor.
And over to GM Burden.
Councillor Critch, GM Burden would like to add. Thank you, GM.
Thank you, through you, Madam Chair, to the councillors. Michelle Baird, Director of Housing Services, is on the line and would like to provide some further context for this.
Thank you.
Through the chair to the councillor, are you able to hear me?
Yes, Director.
Yeah, perfect. So with respect to the men's system overall, very good questions, Councillor. We do know that this has been a challenge in past, and it continues to be a challenge. I think that financial is certainly one piece of it. As we've heard from the providers when they're here speaking with us in past, part of the challenge is around staffing overall. The shelter system right now is quite pressured and struggles to maintain even the staffing they have. So I don't think that this will be easy. I do think it's a necessary step, and I do know that our shelter providers as a whole are looking to find ways that they can continually grow their system, meet the needs of the clients that are there. And I can assure you that the shelter system, the shelter operators, both in the men's and women's system, recognize this need and are willing to work with us. So that being said, I think that it makes good sense to start with one shelter as a pilot program. This is a really new place for our emergency shelters to expand. Space alone will be an issue for them, as you've noted. And so I think we would want to start with one, support them through that operating and see what that looks like, perhaps before expanding further. If we're seeing good success, of course, we can look at that point.
Thank you, Director. Councillor.
Thank you for that. It's helpful. I'm not suggesting at any point here that we expand this beyond the one. That's not been my suggestion. I'm just wanting to get clarity around, again, I'm thinking about a handful of applicants, and I've spoken with all of those applicants, and none of them would apply to this, men's applicants, simply because they don't have the actual space required. They just simply couldn't do it. So I'm just wanting to make sure that we feel confident that we're going to get applicants to this, and if not, that we don't delay the pilot or delay the program from happening if there are other applicants in the women's shelters who may want to apply. That's all I'm worried about here, is that we won't get applications, and then we'll come back here, it'll be delayed. So if you feel that there will be applications, then I'm happy with that.
Through the chair to the councillor, I'm not confident that there will be an applicant. However, it's the men's system, I think, where the focus should be at the beginning. If we do the call for applications, we can do that very quickly. We can work directly with the providers if there is no applicant there. I think you're right that expanding the opportunity to women's system might bring an applicant to the table.
Thank you very much for those answers. I really appreciate the clarity.
Confident of the need, not confident of the success in getting it. Thank you. Councillor Alex Wilson.
Thank you, and through you, Chair, thank you to our staff presenters for not only presenting this information about what's been going on for the past quarter, but with presenting us with the next draft of our opioid action plan. I think conversations about carrots and sticks for shelter operators regarding harm reduction and safer use spaces is one of the first conversations I had. So it's nice, like as a new counselor, so it's nice to be, I think, seeing some of these proposals come forward and working its way through, because I know they're conversations that have been going on for several years in our community. And so thank you for carrying that torch and kind of bringing it forward. I do have some questions more so about the quarterly data and what we can learn from that than the plan itself. Very supportive of the plan in front of us. I'm seeing that over almost 70% of overdoses are happening in a private residence. Would it be possible, I just think so often we get into this narrative of encampments are a place of drug use. And so while understanding that it does also show that more residents in our city are homed than unhomed, and so there's who is overrepresented in these fatality statistics, this also seems to indicate to me that this problem is much broader than encampments. Could you just speak a little bit about what that spatial distribution of where these points of overdoses are occurring, maybe what does that speak to in terms of the narrative of what's going on here? What can that problematize or help us learn? Or what would you kind of, being in this space all the time, push on as significant there?
Thank you, Councillor. Mark, Cashew or Melissa?
Yeah, through you, Madam Chair, to the councillor, thank you for the question. So the data that provides us with location of overdose is data that comes from the Office of the Chief Coroner. So in any suspect drug-related death where the coroner is called. So I start with that only because I think it is important, as you said, is to continue to highlight that substance use is happening everywhere in our community. We highlighted that in our FSA data, that while our lower city FSA data is the highest attributed to opioid-related paramedic calls, there is opioid-related calls in every FSA within our community. Same with a number of 75% of individuals are dying alone in private residences, right? And so, you know, when we present things like our action plan that's continuing to advocate for ways for, or present options for individuals to use in a supervised consumption services, to provide them with the options to encourage them to use alone with another person in the presence of naloxone. You know, informal conversations with with some of our supervised operators of our supervised consumption spaces speak to, yes, there is individuals accessing that service from all across Hamilton. So substance use and opioid use is a broad community issue, and we certainly are seeing that reflected in the data. And just, I don't know if there's anything more Dr. Richardson would like to add to that. Okay.
Thank you, Councillor.
Thank you. That is quite helpful in just like better understanding what's happening in our community. And I think one of the other things that's really important to me in understanding what's happening in our community is the various paths that someone, that a drug, like the opioid in this case, is actually taking to find its way to someone. And so we know that we're having an increasing issue with toxic supply. Do we have any breakdown of the deaths in front of us right now? How many of those are related to a toxic supply or potential contaminants?
Through you, Madam Chair, to the councillor, that's a great question. I will have to go back and check with our EPI team. The office, I don't have the data with me, but if I recall, the Office of the Chief Coroner does provide some detailed characteristics. That is, as you can imagine, data that is quite delayed due to the results it takes from a toxicology perspective. We have, I would say in the first quarter of this year, we did receive a memo from the Office of the Chief Coroner that spoke to the increasing presence of benzodiazepines and xylazine as additives and circulating within our toxic drug supply. That was seen in late 2022. So just to give you a representation on the delay of the data. So those are some things that we do know is circulating from our local opioid surveillance that we do on a weekly, our early warning system. We hear from service providers and community members and users on new circulating substances, and we'll issue alerts, for example, to try and provide some more information. That's where I think continued provision of a drug checking and drug checking surveillance system locally within Hamilton will continue to provide us more real-time surveillance on what is circulating within the community.
Thank you. And through you, Chair, I really appreciate the recommendations about helping people do that testing and ensure that there are safe drug testing distributed more widely in our community. Based on this initial data, would really appreciate that potential for follow-up, but it does seem quite clear that we know that many of these deaths, if not the vast majority, are related to a toxic supply and not safe supply. It sounds obvious, but maybe just seeking that confirmation.
Through you, Madam Chair, to the councillor, yes, we are certainly seeing that it is the increasingly toxic drug supply that is continuing to increase the burden of harms locally. And I would, it is not just us in Hamilton, it is certainly a federal and provincial issue as well.
Thank you, Chair. And I just do want to echo that last bit. It's a federal and provincial issue as well. We right now have the leader of the federal Conservative Party saying that these deaths are related to safe supply. Just an erroneous, false, easily debunkable claim. We know people's lives are on the line here. And this is a priority that's not only costing us a lot of money from a public health perspective as a city in terms of how we respond, but there's a huge human cost to these deaths continuing and to politicizing these deaths for political gain. So I think not only does this give us as decision makers a very clear priorities, very clear areas where we can act and we know what our path is, I think it also allows us to speak out against misinformation, politicization, and some of the things we are seeing countrywide right now that are not only an attack on what we're trying to do here as a Board of Health, but they're an attack on Hamiltonians' lives, and I think need to be called out as such.
Thank you. Very regrettable indeed. Councillor Clark.
Thank you very much. When I'm reading the report, it's clear to me that Hamilton has about 45% higher deaths than the province when it comes to drug overdoses and toxicity. I'm trying to understand what's happening in the province also. So, are other municipalities experiencing the same thing with regards to an increase in opioid overdoses and poisonings?
Through you, Madam Chair, to the councillor, yes, I would say problematic opioid use and the increasingly toxic drug supply is just not a local issue. We know from our other public health colleagues across the province that there is a number of communities that are continue to struggle at the same rate or higher than the city of Hamilton.
Thank you, and I do want to thank our staff for highlighting, as Councillor Alex Wilson indicated, this is not a ward-centric issue, this is a city-wide issue. And that the deaths that are occurring, many of them are in private homes, not on the street. Is that not the case?
Through you, Madam Chair, to the councillor, yes, that is correct.
So can I ask, Chair, with regards to our youth? Earlier today, I spoke about the mental health challenges that our youth are experiencing and the difficulties in getting treatment. Unfortunately, many of the youth, when they're struggling and not getting treatment, they treat themselves through self-medication. So what are we doing with regards to the issue of drugs and our youth?
Through you, Madam Chair, to the councillor. So I'm similar to, I think, what was presented before. I think we have a number of youth treatment. Our youth and pediatric care is coordinated by a number of tables in the community. Specifically to this action table and this action plan, what we did here and what we did speak about as a group is the further discussion around youth-specific RAM clinics, so rapid access and addiction to medicine, rapid access addiction medicine programs to be led, as well as I would also speak to some of the public health priority work that is outlined as well from a mental health and addictions perspective, which continues to be that upstream approach to trauma and violence and informed care, our work in the school programs around upstream approaches, around continuing to build resiliency and coping and problem solving amongst youth, and continuing to increase access to care in that early middle year spectrum. Again, it's a complex problem that requires multiple different interventions at other numerous phases, I would say, across the lifespan.
Councillor.
So let me rephrase the question, if I may. Who's responsible in helping the prevention of drug addiction in our youth?
Through you, Madam Chair, to the councillor, so there's not a sole responsibility. Public Health Services has responsibility as outlined in the standards around community mental health promotion and school health. There is, system-wide responsibility. There's hospital-level responsibility when it comes to provision of acute care health services and treatment, specifically related to drug use. There's responsibilities outlined for school boards. So again, much as it's a complex problem, I think there's multiple ownership of the issue. And that's where I think some of the system coordination that Elizabeth and Melissa spoke to earlier today, as well as some of the work by Director Vickers-Manson on some of that youth and child coordination that is happening currently in the system on some of these issues.
Thank you. Oh, did you wish to, Mark Kasha?
Yes. Thank you. Through the chair to councillors. Councillor Clark, with specifically for the Hamilton Opioid Action Plan, number 7 under medium term specifically addresses development and implementation of new youth prevention programs, and we have identified some proposed leads. Details will be fleshed out once the action tables are established to identify goals and key metrics for implementation.
Thank you.
Thank you for that, and I missed that, and I'm glad you pointed that out. can we get regular, I know we're doing quarterly reports, but can we get regular updates on how we're doing on that youth-led initiative? It's really important that we understand what's happening, because not all the youth go to their parents and say, hey, I'm taking drugs, I need help. They're hiding it, and then there's a tragic loss, and they were left wondering what happened. Can I ask, and maybe this is through Dr. Richardson, Chair, has the Ontario coroner or any provincial body ever investigated the province-wide crisis on drug addiction?
Thank you. Dr. Richardson.
Through you, Madam Chair, the coroner does do the coordination of the death reporting that Melissa's spoken to, and so they continue to do that work. I'm wondering if there's another aspect to the question I'm not understanding.
I understand that they report on any deaths that they believe suspect towards drug poisoning or an overdose. I'm trying to understand who across the province, and I thought of the coroner, would actually investigate the reality that we have here in 2023 of a severe drug addiction crisis and emergency. Does the coroner not have the authority to do broad analysis and investigations in that matter, or would that be the ombudsman?
Through you, Madam Chair. So the coroner's office does do inquests into deaths, and they can choose to investigate a number of deaths together and look at issues. You recall there's actually an inquest into of that sort that happened at the jail here in Hamilton several years ago to look at the issues of substance use within the corrections system. So they do that from time to time. I think the work that they are doing now, where they've set up a more robust system to investigate deaths that come to their attention and look at the extent to which illicit substances, particularly opioids, have been a part of that. They've expanded the data they collect. They've greatly increased the speed with which they process that data and provide it to partners and to communities, is all part of what they would call such a response as what you're speaking to. I think it is part of the reason in ALPHA's recommendations, which this council has endorsed, that we look to the province to set up a collaborative table that looks at the opioid drug toxicity crisis and it takes a comprehensive approach to both look at what the issues are and look at what the needs are and plan for and fund those issues. So that's really a collaborative response across ministries that is being called for to be led out of the province.
Thank you, Doctor. Councillor.
Has the province responded to the call?
Through you, Madam Chair, to this date, not that I'm aware of.
That's disappointing. So if the province is not picking up the call of multiple jurisdictions, then what's the next step for this municipality to lead the charge? How are we going to get this addressed province-wide?
I can add, just as the prerogative of the chair, that there is an Alpha conference beginning tomorrow in this subject matter, and the resolution will be front of mind, and there will be efforts made to underscore the significance of it. Doctor?
Through you, Madam Chair, I mean, from the standpoint of what we can do about it here in Hamilton is this continued advocacy, raising awareness of the issues, looking at what we can do locally. We certainly ensure collaboration, coordination across the province through the various groups that we're members of. There is a Council of Medical Officers working group as well, which is part of ALPHA working on this issue, which Melissa and I both belong to. And so we continue to do what we can through coordination of action and sharing of information while continuing to call on the province and federal levels to continue to address the issue and expand their response.
Thank you, Doctor.
Thank you for the chair's intervention with regards to the ALPHA conference, and I'm pleased to hear that that is an item that will be under discussion because it's needed to be discussed. The last question I have, and I think I raised this before, is rehab stats and recidivism and successes, numbers of beds available. Do we have any of that information from organizations that are providing rehab, whether or not it's publicly funded or private?
Manager Bixa.
Through you, Madam Chair, to the councillor, I don't have that with me. What we can bring that back, or we can bring that back to the opioid action table as part of the reporting going forward to continue to articulate that need to assess the feasibility of it. I'm just recalling early data that we did have from 2020 to 2021 really did speak to, we have some data around initiation of treatment and completion of treatment plans. I don't have the most up-to-date data with me today, but I believe right now from a treatment perspective, that is what we do have access to.
Thank you.
Not number of spaces.
Thank you.
Thank you very much for your responses. I do support the recommendations. Those are some of the questions and concerns that I have in this report. Thank you.
Thank you. Councillor Danko.
Thank you, Madam Chair. Appreciate the discussion today, this crisis in our city. Looking through the action plan focus, the 3 points to reduce deaths, to reduce harms, and to increase access to treatment, I wanted to focus a little bit on the treatment point there. There's a lot in the recommendations and the report on drug use. I'm not clear exactly how much focus there is on addictions treatment. There is some discussion on abstinence safe spaces and in long-term on opioid therapies and rapid detox programs. But I think from the perspective of a lot of residents, there'd be a desire to see a stronger focus on addictions treatment rather than enabling illegal drug use.
Through you, Madam Chair, to the councillor, thank you for your question. So a couple things. When we outlined the action plan, we also spoke to some immediate actions to continue to reduce the immediate harms associated with it. So again, that's safer use spaces and ways to understand what's in your substance to really reduce the harms and reduce the deaths, so that we can then facilitate across the continuum of care of increasing the ability for individuals to enter into or access treatment. Through this process, and one of the medium-term actions, we speak to better and strengthened pathways. We certainly heard that from different all of our frontline care providers in the community of, at 1 o'clock in the morning, what's available to increase, to help transition individuals into service. So again, I think with that action plan, it does come to how is the opioid action table going to continue to advocate for more funding for treatment beds, continued new and novel local programs around provision of services and for when individuals are ready to access that continuum of care. We know treatment and recovery is also a continuum. It's not linear, right? Individuals can come in and out and access, and it's important that those care pathways are established and available for any individual using substance. But it is that two-piece. We have a very toxic drug supply in our community. We need to continue to reduce the harms and to continue to facilitate that access to treatment.
Thank you, Manager.
Thank you. On the toxic drug supply, I've heard that a number of times this morning, and also the level of addictiveness of the drug supply as being a contributing factor, that it's highly addictive. You did speak with Hamilton Police as one of your community organizations. Are there resources or initiatives in place to focus in on stopping that toxic drug supply on the enforcement side, through police? I'm just curious to hear what their contributions were to the discussion.
Yeah, through you, Madam Chair, to the councillor. So certainly police would have a role from the trafficking and enforcement. That certainly at a local level, but also recognize that's federal jurisdiction and work coming in as well. Hamilton Police, again, has been a longtime partner of the Hamilton Drug Strategy, sitting on the steering committee, and so definitely have shared initiatives that they have going on that they are currently employing through the use of their navigators programs or the RIST program, and again, really contributing on what is helpful from their perspective. Again, how when they are providing care, like I said earlier, that 1 or 2 o'clock in the morning, how can they continue to link individuals to services, what's available in the community to really facilitate provision of health and social services for individuals.
Thank you.
Manager.
My last question was on the drug checking recommendations. So I have a couple questions just on perhaps the logistics of that, because we are talking about illegal substances, and if you're doing mass spectrometry, I don't think it would be on site. So then you're handling and transporting illegal substances. Just on the logistics of that, how does that work?
Yeah, through you, Madam Chair, to the councillor. So that's a great question. So. So when we're talking about drug checking, we're talking about two different prongs. So one from a mass spectrometry or the point of care units that are referenced. Some other examples that we've seen in other communities, they're set up at supervised consumption spaces. So those spaces have an exemption to permit illegal substances to be on site and used. So individuals bring their substances there to test, and then also, consent for that to be included as part of, we've tested 8, 10, 12 samples today, and that all have the various composition. Again, a mass spectrometry services, usually those are incredibly expensive machines, often held at hospitals or academic organizations. Organizations then would work with Health Canada to get an individual exemption for those types of spaces. For that purpose is to allow that type of substance to be tested on site.
Thank you. My last question, still on the issue of drug checking, is there any risk of liability to the corporation of the city Hamilton if we are facilitating and funding a drug checking program and then people are consuming illegal drugs on the basis that, well, the city gave me this test strip and it's safe, and then if it ends up not being safe, is there a liability back to the city and taxpayers as a result of that?
The residents, yes.
Through you, Madam Chair, to the councillor, while I am not a solicitor and cannot provide legal advice from the city, that as part of a take-home kit or distribution, that would be our work with our city solicitors on how to roll it out, and procurement of the testing strips, and ensure appropriate consultation and sign off with our legal services in the provision of these, as well as reaching out to other communities on recommendations from that moving forward.
Thank you. And other municipalities are doing this, just to be clear. I think Toronto was one in the report. So those discussions have taken place in other places. Appreciate the discussion. Thank you.
Thank you. Councillor Nan.
Thank you, through you, Chair. Thank you to our staff for the overview, the presentation, to the table for helping come up with the list of recommendations, really appreciating the 3 tiers of the immediate, mid, and long term. I'm really glad to see the robustness of this action plan, and really, really appreciative and supportive of everything that's here in terms of a comprehensive list of actions. I have to share just quickly, I had the privilege of attending the Federation of Canadian Municipalities, and in speaking with several colleagues from across Canada, from small communities, rural communities, to mid-sized communities, to urban, large centers, the crisis is real, and every single community is dealing with a sober assessment at this point. And that assessment is looking at what is working and what is not working based on the needs of those who are using, and the deep, deep need to move away from stigma and really digging into this conversation from the perspective of healthcare and a system of care. And it was interesting for me to hear and learn from some of my colleagues out on the West Coast, particularly around what they're calling a failure of residential treatment centers, in so much that folks who are coming into those treatment services aren't leaving with the wraparound supports that they need, going back into their communities, their homes, and remaining able to cope with the circumstances that have led them towards the path of requiring self-medication and unfortunately turning towards highly addictive and toxic drugs. And so I appreciate the continuum that you've been talking about, that staff have been talking about, in terms of this is a crisis, and at a point of crisis, what we need is intervention. That intervention has to be truly and wholly rooted in being one of harm reduction and saving lives. And may we get to a place, right, through relational deep support over a long period of time, which is going to require deep investment from the province and the feds, in order to enable people to thrive and get to a place of healing and reentry into society in various other capacities. So appreciating the spectrum that's being discussed by staff here, and our ability then to be learners, educators, and then communicators with our residents about this crisis. Could you speak a little bit about the Safe Consumption Site 18-month pilot? I had a quick question related to that, and that is, should there be a successful applicant, through you, Chair, what would be the role of public health in supporting that applicant in managing some of that potential stigma-based pushback in the neighborhood or adjacent area? And is there a role for public health there in terms of supporting that public education, helping address local stakeholder issues, local neighbor resident issues, etc.?
Thank you. Who would like to? Dr. Richardson, please.
Perhaps I'll start off and then turn back to Melissa. So as you are aware, we've worked with in developing a set of guidelines for any supervised consumption site to go forward with. Now, there's only a requirement for a supervised consumption site that is a CTS to get municipal approval, but we've put together guidance for any type of supervised consumption site, including this one, which begins with, please call us so that we can work with you to support the application process and what we think are good ways to move forward, good means to engage community, all of those pieces. So we would look with Michelle Baird at putting that guidance into the call for applications, along with the evaluative framework that you'll be seeing next month, or in August, I should say, in terms of another way to continue to look at the data and understand what's going on. So we would be working with them. Certainly the shelters that we're speaking about are well versed in working with their communities and speaking with others. So we think they would be more than adequately prepared to lead that sort of initiative. But we would be able to help support them in doing that work. I don't think we could take it over. We don't have the resources either to take it over or do it for them or do any of that sort of work, but we would be able to work with them. And that would be one of the reasons why we're asking for the additional staff person to help support the initiatives that are coming out of this. So Melissa, did you want to add anything?
No, thanks.
Thank you, through you, Chair. Thank you, Dr. Richardson, for that response. And I would agree that many of our shelter providers are already very capable of managing some of the potential tensions in their community just by the nature of the service they're already providing. But one of the key things I think for us as a municipality that supports our action plan that's here is that cultivation of best practices and the stakeholder tables, or even the ability for a successful applicant to be supported to have a space where folks can come in to address issues preemptively as best as possible, so that we're supporting that partner to succeed, to mitigate any negative impacts of a consumption treatment site in their neighborhood, and just wanting to really make sure that we're thinking that through and equipping, connecting the dots, and enabling us as a municipality to be able to get to those mitigating conversations earlier than later.
Yeah, I'll just say through you, Madam Chair, to the councillor, very much appreciate the point and clarification and request for this process. And I would say this is as Dr. Richardson highlighted, this is ongoing work that is happening not only, individually one-to-one with public health services and some of our operators, but also across the system. The GHHN, as highlighted today, has a harm reduction and safe supply working group of shelter providers and again, it is a very, this sector is very collaborative, particularly around supervised consumption sites. It's been a similar group of partners who have, worked through these issues for the past five years, helping sites with applications and come to fruition, or sharing experiences. The team at YW has been very vocal on, willing to share, lessons learned from their application process. So really there is a supportive network within this community to help move these initiatives forward.
Thank you. Those are my questions.
Thank you, Councillor. Thank you, Manager. Councillor Jackson.
Thanks very much, Chair Maureen Wilson and Manager Bixa. Good to see you again. I think you were an integral part of our COVID-19 updates over the last couple of years, and nice to meet you, Dr. Katia, as well. Good luck in your residency at McMaster. Just a quick opening comment, then I've got a series of questions, Chair Maureen Wilson. Back in the 90s, the late great colleague of mine and MPP, Dominic Agostino, convinced me that the region needed to embark upon a novel initiative of a needle exchange mobile van to reach those that needed to be reached. From a needle exchange standpoint, every part of my being was heavily resistant to it at the time. He convinced me it was the right thing to do, and I think we had a tremendous measure of success with that. So that's an opening. Fast forwarding to today with this whole narcotics plan that you've brought forward, Manager and Doctor. I have a series of questions because I have some cautions within the questions as well. So please help me and educate me further, please. So the thrust of this is to eventually open up more SCSs, correct? Through you, Chair Maureen Wilson.
Manager.
Yeah, through you, Madam Chair, to the councillor, yes, both in the immediate term as well as continuing to look for options in the longer term in the community.
Are other municipalities neighboring us, the Burlington, Oakvilles, the Niagaras, Kitchener, Waterloos, Haldimand counties, are they going down a similar path And I have a supplementary question to that, depending on, Manager, how you answer that. Through you, Chair Wilson, please.
Through you, Madam Chair, to the councillor. So what I can say is that every local region has their own individual local context. So if I just want to step back a little bit. We have talked broadly at this table around consumption and treatment services. So there's currently 17 operating in the province. There's one in Waterloo. There's one here in Hamilton. Halton Region currently, to specifically answer your question, does not have any supervised consumption services operating. At Niagara and St. Catharines do. Right now, but yes, across the province, there is 17, and those are just provincially funded. We also know in Toronto, there's other sites that are operating that don't require provincial funding and are funded either through private donor or through organizational funding. And there also are a number of urgent public health needs sites operating, for example, like the one at the YW, and I don't have numbers on how many of those are currently operating within the province.
No, I really appreciate, thank you for that information, Manager, because, and I won't get into the debate today, but similar to the OW story I shared with Council 20 years ago, and with staff's concerns outlined in the report about the sanctioned tent sites proposal, I want others to be doing their share as well, because Hamilton's a very compassionate community, and I just don't want it to end up being where Hamilton, if you will, becomes the destination place because others aren't simply picking up their share. Through you, Chair Maureen Wilson, when you both spoke about the downward trend, but you were puzzled by it, I didn't detect any bit of happiness with the downward trend, or did I just miss that because you're still puzzled by it? Through you, Chair Wilson, please.
Manager Bixa.
Through you, Madam Chair, to the councillor. Yes, of course, we are pleased to see a downward trend, both attributed to opioid-related, or drug-related deaths in our community. You know, I'll be remiss to say we saw our highest quarter of opioid-attributed overdoses from this past quarter, and again, I think it's continuing to. From one quarter of data, continuing to recognize this is a significant concern in our community, and that we need to continue to address. And although the number is decreasing, it still represents a significant impact to our community.
Thank you, Manager. And Chair, I'll look to you in terms of how I'm doing with my time.
2:35.
Thank you. Let me ask, with the hospitals, you're suggesting, I think if I heard you correctly, as we're looking at potential applicants, weren't hospitals absolutely resistant to the safe consumption site that we recently approved? Or am I missing something? Or are you hoping this time to find a persuasive way of convincing them to possibly become an applicant? Through you, Chair Maureen Wilson.
Through you, Madam Chair, to the councillor. So what we do know about substance use is substance use continues across the spectrum whenever you're accessing services. And our conversation and dialogue with the action table, what you'll see as an immediate action is around safer use policies. So our partners, our hospital partners, going back and looking at how substance use is permitted or used within their organization, and potential interventions that they're able to bring forward that works within their organization and their mandate and their spectrum. Again, from an early planning, I would say that's continued work of the opioid action table of moving forward. Some of the longer term initiatives that we have on the action plan is, again, continuing around continued supervised consumption spaces. I think really continues to come back to the philosophy around providing an infrastructure in the community for safe consumptions and for individuals to be able to use their substances as, part of their spectrum of care and health care. And so looking at the action table would look at, with its partners, different agencies and the longer term that might continue to be able to provide services.
as a layman, I just thought the hospital environment and the hospital community was such a natural for potentially hosting a site, but when they resisted strongly, if I recall, in our debate of several months ago over the safe treatment site, I was quite shocked, quite frankly. A couple more questions, Chair Maureen Wilson. So I'm in the business, I want to save lives, but double bonus, I'm hoping we can transform lives. So through you, Chair Maureen Wilson, to Manager Bixa, help me understand now with more of the SCSs you wish to open. We want to save lives, get those off narcotics. How are we hoping, though, to transform their life and not just put a Band-Aid on their situation where there'll be recidivism, there'll be repetitiveness, that we'll see the same individual potentially, hypothetically, back at the site over a period of its life? I'm just trying to understand, are we also in the business of doing our best to transform the life that comes into the SCS? Through you, Chair Wilson, please.
Through you, Madam Chair, to the councillor. So again, this comes back to the continuum of care. Supervised consumption sites do provide wraparound services. So those are essential connections to health and social services. So it can be access to treatment, how to continue to access different, if housing is needed, for example, and to really continue to identify what the goal is of the individual in this continuum of care and how they can support and connect those further, connect the individual further within the community. Again, when we speak to supervised consumption spaces, it really provides an area to use substances safely in a supervised manner to reduce the risk of death and harmful overdoses, and to continue to build that connection and continuum of care. As we spoke earlier, recovery is a continuum and can enter in and out at multiple phases of one's life. And so continuing to provide these important services within the community helps to continue and keep that connection and those wraparound supports to health and social services.
Manager, I appreciate the paramount mission is to save the life, but I'm hoping you will continue to take under advisement. Sounds like you're there, but whatever greater support you can provide to ultimately transform that life permanently off of narcotics, for me, would be just something to totally celebrate. Last question, Chair Wilson, to the delegates, the presenters. So I'm hearing many are dying in private homes. Is the goal that if we open up another SCS, they will come out of their home, cross the road, and go there where they can get some help and treatment? Is that the idea? That's my last question, Chair Wilson.
Manager?
Through you, Madam Chair, to the councillor, yes, it's continuing to provide multiple options for individuals to use substances and in a safer manner. So yes, absolutely. Provision of more supervised consumption spaces allows individuals to not then use alone at home in their private residence. Again, we know this requires multiple different interventions. Provision of these services, along with continued messaging around not using alone, using with someone, ensuring you have naloxone with you, are other key strategies.
Manager Bixa, as always, you've been a wealth of important knowledge, at least for this councillor. Thank you, Chair Wilson.
Thank you. Councillor McMeekin, followed by Mayor Horvath for the first time.
Thanks, Madam Chair, and thank you for the presentation. It very enlightening. I'm a supporter of the intelligent use of supervised consumption sites. I just think that makes sense versus 100 unsupervised in neighborhood park sites that have their own difficulties. I also believe we need to meet people where they're at. We need to find ways to connect, particularly if we're going to take on the task of not just saving lives, but transforming lives. That talks to the need to establish a relationship that's ongoing and identifiably helpful. So I would flag that. I appreciated Councillor Clark's always incisive comments about who's in charge, who's responsible, how do we get even to first base, let alone around the plate. And I think his moving to identify and draw attention to the crisis is instrumental launching point for that. I've always believed that if you've got a serious problem, the best way to deal with it is to shine a light on it, to make it highly visible, to challenge people to engage with it. So my questions relate to public education. Having done a lot of public education work in the mental health field myself over the years, I understand how fear and stigma can put a lot of people off any ability to move forward. So I'm wondering, you mentioned mobile units. That's had some history of success in some communities, as have sanctioned communities. I know one up in Kitchener where identifiably 26% of the residents have an addiction problem. But because it's in a gated community for homeless folk with pharmacists coming in, half of those people are engaged in a treatment program, Madam Chair, which is helpful. So that ties into what Tom was saying. So enhancing the broad-based knowledge. Everybody knows there's something called fentanyl out there and it's killing people, and but they're almost scared to death even to ask about it. What creative entrepreneurial things can we do in the public education sphere that will help people who want to save and transform and get engaged to understand why intelligent use of safe, supervised consumer sites makes sense and why they should embrace it. What can we do from a public education perspective? And what's our role around this horseshoe? And as people who have some enhanced understanding of the problem and really would like to do something about it.
Yeah, through you, Madam Chair, to the councillor. So that is a good question, how you continue to get the message out. We do know that supervised consumption sites are evidence-based, effective programs that do reduce overdoses and deaths. There has been data that shows that they do not increase crime, for example, in the surrounding areas. Again, I think it continues to be continuing to share the successes of the sites. Council, Dr. Richardson's mentioned this, but Council will also receive a report in August about an evaluative framework that Public Health Services is developing to, that would be a dashboard, for example, that would continue to demonstrate the success of supervised consumption as an intervention in our community. And again, I think it also continues the bigger question or the bigger issue around substance use in our community is that it is impacting everyone and that we need to continue to provide interventions in our community to keep individuals safe and to keep them alive and to reduce the harms associated. So I think it's more of that continued messaging from the community around the importance of these services, how we continue to help and serve our residents in the community.
Councillor, just a reminder to my colleagues, we have another, this is really important, but we have another report and a motion and something else. Thank you.
Final quick thought. And I hadn't thought of it until you mentioned it in your presentation. You talked about a series of task-oriented groups. Mm-hmm. I think that's a really good idea because none of us can do everything everywhere for everyone all of the time. Mm-hmm. So we can split it up so that we have a series of well thought out and strategic approaches to different aspects. I would want to respectfully suggest, if you haven't already anticipated this, perhaps you have, that one of those task-oriented groups ought to be public education. Fair ball?
Thank you.
Yeah.
Thanks.
I'm seeing
take
a
that
nod.
with us.
Thank you.
Thank you.
Mayor Horvath.
Thanks, Chair Wilson. I really appreciate the conversation around the table. It's extremely important, and I'm only just going to put one fine point on why we're having this conversation. People are dying, and when we look at things like the pandemic, when the rate of death weekly was in fact, I think at the height was in fact lower than the stats that we're talking about today in the report in terms of the number of people weekly dying from suspected drug-related death. That's, from my perspective, all we really need to do to put this into perspective in terms of the crisis that's playing out daily in our community. So very much appreciate the report, the action plan, the thoughtful way that this has been discussed today. Very much so. Thank you.
Thank you very much, Mayor Horvath. There are no further first-time speakers. I have Councillor Clark as a second time, sir.
On the report itself, please. Thank you.
So to Manager Bixa and to Mark Kasha, thank you very much for your presentation. Very appreciative. And what can we do as a Board of Public Health? Well, we can talk about it in terms of health and not in terms of morality, and that this is a crisis. Thank you very much.
Thank you.
On the presentation to receive, moved by Councillor Wang and seconded by Councillor McMeekin. On the presentation to receive the presentation, please.
Sorry, I just missed the seconder.
Councillor McMeekin.
Councillor McMeekin?
Councillor McMeekin, thumbs up? Yep. Thank you. That carries 12-0. Appreciate it very much. On the report, let's get it on the floor. Councillor Nan moves it, seconded by Councillor Alex Wilson. I have Councillor Clark, followed by Councillor Kazar on the report.
Thank you, Chair. I appreciate that. So can I ask, I guess it would be Dr. Richardson, item C in the recommendation with regards to the drug checking and surveillance pilot. Councillor Danko asked about liability. Has these recommendations been passed through our legal division?
Through you, Madam Chair, not at this point, no.
When would we do that? Because item C, I share my colleague to the right, Councillor Danko, although that's not a comment on his political philosophies, it's just that he is to the right of me. There very well could be liability for the municipality. And where would we receive that advice?
Through you, Madam Chair. We would go through that process as we design the program, so we can reach out to legal services and look at what might be needed. As Melissa described as well, we'll consult with other municipalities who have put this in place and other organizations that have put this in place, because of course across the country they're not all municipal, and just look at what have they both had in terms of what they identified as things that should be put in place, but also any experience that they've had with legal issues as they've had these programs operating.
Thank you.
Not to be disagreeable, but wouldn't it be more prudent to receive that legal advice before we pass this recommendation?
Doctor, you're...
Through you, Chair, given that we know that these programs are up and running in various places across the country, we didn't think we needed that advice before recommending to move forward with them, but would look at that as we do with any program that we're setting up where legal advice is needed. We would consult with the lawyers along the way.
Thank you. Councillor?
I guess I have some concerns about doing it in that manner. The second question is with regards to, in the report, I'm looking for where we are going to be tackling the issue of drug rehab. And I'm not seeing an extensive, comprehensive way of encouraging or getting more drug rehabilitation. What I am hearing from parents whose kids are experiencing drug addiction, some of them have the child, or through perhaps some encouragement from their parents, have came to the realization that they want to break the habit, but then there's a waiting list to get into those services. So how are we assessing the impact of the rehab services that we have in the city of Hamilton?
Through you, Chair. So when we look at the recommendations as they're outlined, and as you've heard from Melissa, all of the initiatives are meant to link people with the spectrum of care that is needed. And so whether we're talking about supervised consumption sites, or as we go through in terms of the pathways work, they're meant to continue to look at how do we connect people with the continuum of care that they're needing and which they're willing to engage with at the time. The specific referral to residential treatment and to rapid access to detox and addictions medicine comes in that 12-month action plan, 12-month component of the long-term actions. And so that is where the committee felt that they needed some more time to look at the issues, understand what is needed where, and understand the system a little bit further, and then look at how could we increase access to treatment in those forms, both, as I said, in terms of rapid access to addictions medicine, but also to longer term residential programs. I just underscore, and I think you mentioned it earlier, Councillor, that the connection between all the different elements was important as well, and so that any client wasn't simply leaving residential treatment without access to the supports they needed to stay connected to any treatment that they're on, whatever it may be, the housing that they need, but to have ongoing supports even after a period of residential treatment. So very much looking at that from a system standpoint and making sure those elements are tied together.
Thank you. And it's important that we highlight that, Chair, because I don't want to be seen as a municipality that's simply throwing their hands up in the air saying, well, there's a drug addiction crisis. They're going to do it anyway, so let's check the drugs to make sure they're safe. And that's not what we're doing. It's a much more holistic approach to how we're dealing with substance abuse in this municipality. And it's important that we share that so that residents are aware that we are looking at rehab, we are looking at treatment, and it's a part of this process. Now that I've spoken, I'm not sure if I can make a motion, but on item C, I would like it to be reviewed by legal before we approve it at council. Is there a way of doing that?
Dr. Richardson?
Through you, Chair, I don't think I can speak for legal services in terms of their workload. I would think it's unlikely that they can turn it around as quickly as that, knowing just how busy they are. It would be, you could put a contingent on it as well, that it be reviewed by legal services prior to commencing the pilot. That might be an alternative way, or that we could report back to committee and council through a communication update as to whether that review had been completed and we're able to move forward. So I think there's a number of ways we can meet that, but I wouldn't want to commit my colleagues in legal services to a review within the next 2 weeks.
So I'm left in a quandary because I'm concerned about approving a recommendation that could have liabilities to the municipality, especially with tort law in Ontario, where just 1% of that liability means that we're on the hook for all of that liability. And I don't know how we get that review done before council has to deal with this.
So,
go ahead, Chair.
yeah, so I thought I thought I heard from Dr. Richardson that in the program development, that program, once it's defined, will be reviewed in terms of the product, if you will. And then at that point, we can have an overview that will address perhaps the counselor's concern while treating it like the emergency that it is. And you can go ahead and shape the program and then report back prior to its liftoff, if I'm understanding that.
To the chair, yes. Indeed, as Melissa's just reminded me as well, that knowing exactly what the program's going to look like is part of what legal will need to know in order to provide that advice. And so that will take, again, more time than just the next 2 weeks.
Councillor, does that address your concerns?
I'm not sure if you can recall your exact words at the very beginning, but I think that would address the concerns. We need legal oversight on this. We could be venturing into something that could be very expensive if things go wrong. And I'm not sure of how we word that, but I guess before the launch of the program, that legal be included to protect us.
So I'm hearing they need a product in order to comment on, and I'm seeing a nod in response to your comments from Dr. Richardson that in some way, shape, or form, perhaps through a communication update or whatever form that might take, we'll receive that assurance. And if we don't receive that assurance, I'm sure you would advise us also.
So can I ask then Dr. Richardson at least be able to explain this at council so that residents are fully aware that we're not jumping into the pond without having a legal review of the pond?
Doctor?
Through you, Madam Chair, perhaps we could amend C to say that a one-year drug checking and surveillance system pilot be implemented in a manner satisfactory to the city solicitor.
That would be fantastic. Thank you. Thank you very much.
Thank you.
I'd move that or a friendly amendment. It doesn't really matter as long as it's in there for me.
If I may ask Elsie Gauthier, do we need to have a vote on the amendment, or can we just take it as a friendly-ish? A vote? Okay. So Councillor Clark is going to move the amending motion. And I think I'd like to recognize Councillor Kazar, and then we'll come back to the motion, please, and thank you, and that will give you a little bit of time. Thank you.
Thank you, Chair Wilson. I listened carefully to the discussion, and I'm fully supportive of the recommendation. I just had a question procedurally, I guess, relative to the budget about B, C, and D. I recognize that the language says to be included in the 2024 budget versus referred to. So as I've been learning over the last 7 months, I think we would want that to be referred to. So my question would be, is that intentional, or is this something else that we could amend agreeably?
I was going to ask a similar question, but different. But if I could seek that confirmation on the wording from GM Burden, perhaps, or Dr. Richardson.
Thank you. Angie Burden, General Manager of Healthy and Safe Communities. So Dr. Richardson and I are conferring it is intentional, which would allow us to actually start the work this year without having to delay until the end of Q1 for 2024. Again, we're at council's direction.
So just if I could seek clarification, my question was going to be, we can't assess a pilot success from now up until budget deliberations begin in January, because we still need that runway in order to create the product. So I thought it was kind of, I didn't understand why we would be going and asking for funding when we don't have anything to assess that ask on. So I think Councillor Kazar and I are on the same place. And are we securing the funding in the budget through this wording or not?
Mm-hmm. Through you, Chair. So the intent is, as Angie said, is to secure the funding now in order to carry out the pilot. Because as you said, we wouldn't be able to have anything wrapped up, but we also could start it until we had the funding secured for it to carry it through the full term. And the terms for these are about 18 months long for it. So it does transition over a budget year.
Councillor Kazar.
Yeah, so I'm not sure how to proceed there, based on, every other circumstance that we've had. We are not in the 2024 budget process yet, so.
It's almost like a multi-year operational ask.
I'll cede the floor to the mayor.
Recognize the big boss here.
Well, no, I'm just, thank you for recognizing me on just on this same topic. It seems to me what they're asking for is that we build this pilot project into their base budget, so that when they come forward with their budget in the budget process, this is already built in and not seen as an enhancement, but rather a built-in project. That's what my assessment is.
Thank you, Mayor. I'm seeing nods, but Councillor Kasar, you have the floor.
Right, and that's what I understood as well. It's just.
Worded.
Right, but this is a budget, it would be a budget increase, right? Which would be a, either business case or a council referred item, which is different than our typical process. So I'd really be interested in hearing opinions around the horseshoe here on how we treat that. Because I understand the explanation, you need to have surety of funding, so I'd get that, but it steps outside of our regular process, which I'm uncomfortable with at the moment.
Thank you, Councillor. I'm looking to see if there's any further comment from the bench, and I don't see any. Would anybody, Councillor, are you done? Okay. Any other comments, questions? Councillor Nan.
Thank you, through you, Chair. Just on the budget piece here, I'm clear that it's an 18-month pilot and that we're being asked to approve it today in terms of recommendations in order to enable staff to proceed. We are facing a crisis. I think that we need to prioritize funding the really great action items that have come forward. If that means there's a rollover cost into 2024 in order for us to see progress made on the recommendations here before us, I think that's appropriate. And it would be itemized as a pilot program. It wouldn't be a overarching base one. So I just wanted to clarify that. So any funding requests that are tied to this recommendation that are going forward into 2024 are all associated to the pilot, correct?
Thank you, Councillor Nan. GM Burden.
Through you, Madam Chair, to the councillor, you are correct. They all are connected to these pilots. Dr. Richardson and I are conferring about the opportunity we could go back to finance and see if there's a different way of structuring it to allow for the goals of the program to be executed, but also satisfy some of the concerns around having a bit of a different process.
Thank you for that response. Through you, Chair. I'm confident to go forward. I want to see these pilot programs get off the ground and be able to be implemented by staff with some confidence with guaranteed funding for the duration of the pilot program, understanding that that does mean technically we're making a decision about 2024 finances, but I don't see how else we could proceed with the decision today. I wouldn't want to parse out a portion of the months of the pilot to 2023 and then not carry it over into 2024. It just, for me, would create some precarity around the approval today. Thank you.
Thank you. I recognize Councillor Wang.
Thank you. I agree that we do need to place an emphasis on this, and this should be part of our package of tools moving forward as we speak about these crises. But is there an opportunity to defer this decision until either council or the following council meeting? That way it buys a little more time for staff to confer with finance, as well as our sort of background on doing some more background research on this?
I guess the question has to be asked, are you uncomfortable with the wording, or are you uncomfortable with the concept of funding a pilot, which is a multi-year, and it needs to be assessed as such? So I'll just leave that question with you. I think I see GM Burden's hand up.
Through you, Madam Chair, to the councillors, Elizabeth and I are just conferring. We did confirm this wording with finance. This is the recommended approach, given that is a multi-year pilot. It would not be feasible for us to start these initiatives without having the funding commitment to complete them, just in terms of the human resources that are involved and the efforts of staff to get it underway. Thank you.
Okay. I guess those are all my comments then.
Thank you. Councillor Alex Wilson, followed by Mayor Horvath.
Just happy to move forward on this. I feel ready to vote right now. Similar to how sexual health funding, as we talked about earlier, is part of the core mandate, so it comes up in the departmental budget, just really echoing that clarity that the mayor brought. No issue in considering opioid response as part of the core mandate or the core budget of healthy and safe communities. We've already declared the emergency. It's already something we want to be part of it. I really struggle with whenever we do something new. I think council referred items as part of the 2023 budget. What we're seeing is this is a budget process that you only have one check for a status quo continuance, but you have like 3 to 5 checks if you want to do anything new. If we've declared an emergency on this, we've declared it to be a priority. We've already done some of that work. It's going to come back to us again and again as part of the budget anyway. We'll just have to look a little bit harder to find it when it does come back. So I'm very happy to move forward with this today as presented.
Thank you, Councillor. Mayor Horvath.
Not dissimilar to Councillor Alex Wilson's comments. Actually, they said some of the same things I was going to say, but we really do have to stop kicking stuff down the road, folks. We have a crisis, multi-pronged crisis, an emergency in front of us. We need to start really putting our shoulder to the wheel and getting some programs in place to help us manage these crises. I don't know that we can solve them, but certainly we need to start doing that work and taking it seriously. It's our responsibility to do so. And I would simply ask the members of council of committee rather, to take that responsibility seriously by passing this motion or this recommendation.
Thank you, Councillor McMeekin.
Thanks, Madam Chair. Building on some of the comments most recently made, I can recall being in an airport and seeing a sign up with the definition of a successful pilot. That's one who lands as many planes as take off. And I think the difficulty with pilots is sometimes they get launched and they run out of fuel when they're still up in the air. And I don't want to see that happen, so I'm for moving forward today, as per the mayor's comments. Thanks.
Thank you, Councillor. I don't see any further speakers. I know we have an amendment on the floor, and I was wondering if Elsie Gauthier, would you kindly put that up on the screen, and then we'll move to the report. Thank you. And I see the public works staff have entered the building, no pressure. C, Councillor Clark, are you comfortable with the friendly?
Yes, I am. And if you can come back to me, a quick comment on the report, thanks.
Absolutely. Okay, so seconder, Councillor Danko. So everyone understands the slight modification in the recommendation C. We can vote on that now. Thank you. Thank you. That carries 13-0. On the report's recommendations, Councillor Clark.
Thank you. I looked through the recommendations closely. I do not see a report back about the pilot. So what is the intention? Is the intention to have an 18-month pilot, and at the 12th month, we'll review that pilot and be prepared to present that review back to council after the 18th month? Because the idea would be that you want to be able to report back in sufficient time should the council decide to proceed with it as a formalized part. of our ongoing process or not? So where's the review built in?
Thank you, Councillor. Dr. Richardson.
Through you, Chair. In terms of the 18-month men's supervised consumption site pilot, that's recommendation E, is that we would do the evaluation of the shelter site and report back in Q4 of 2024. That was designed to give adequate time for the pilot to get up and running and operate for 1 year. And then we would do the evaluation and bring that back, as you say, Councillor, in time for budget considerations for 2025. But the inclusion of the 2025 funding in recommendation D allows it to continue to operate until that decision is made by council, rather than to stop it and potentially start it again.
Thank you, Doctor.
Thank you. And with respect to item C, the report back?
Through you, Chair. So for this one as well, we would anticipate reporting back to you in terms of progress of getting that one up and running, and then we would continue to report back on that one as it went. You're right, in this case, it doesn't have a specific evaluation component listed as a recommendation, but we would similarly be bringing back the experience with that pilot by the end of 2024, so we could look at what would happen in the following year.
And so I would suggest that we would need to include that somewhere in the language in the recommendations. You can't have a pilot without a report back. Otherwise, it's just a new program.
So E is, recommendation E is specific to the proposed men's shelter consumption site in terms of that report back. In terms of that which was referenced by Councillor Clark, could you help us in seeing if we can address that concern? Anyone on the bench?
Chair, absolutely. We can add to the recommendation, sorry, I'm scrolling through the report, that the one-year drug checking and surveillance pilot be implemented and that a report be brought back. I'm going to suggest in this case in June of 2024.
Elsie Gauthier, C, did you get that? Sorry, Councillor. Then we could put it up on the screen. Councillor Clark, beg your pardon.
Sorry, Dr. Richardson, what was the timeline?
June 20.
I'm rethinking somewhat myself. Elsie Gauthier. How about we say Q3 2024?
That would be acceptable to me. I'd be happy to move it. Councillor Danko will second it for me.
Okay, so it's up on the screen, and it's, if I can draw folks' attention to recommendation C in the report, and Elsie Gauthier has put the slight change in bold. Okay?
I'm happy doing that as a friendly, if that's acceptable to the clerk.
So we'll maybe do it like the last one, and it's been moved and seconded, and if we can have a vote on that language, and then we'll get to the report, which is, yeah, thank you. Thank you, Councillor. Okay, the vote is up. Thank you. This is on slight amendment to C, okay?
And just one last comment when we're done.
Please, thank you. If I could just get the vote recorded, and then we'll, thank you, Councillor. That carries 12-1. And Councillor Clark.
Thank you, Chair. And I understand the mayor's concerns about kicking things down the road. I think the questions of my colleagues about the financing of this is not a question of trying to kick it down the road. It's a question of trying to follow our own policies. And putting things into the 2025 budget, I don't recall we've ever done that. So it is worded uniquely, and if Mr. Zegarac is fine with it, then I understand it. But we have to be really careful that while we're moving in a bold fashion, that we're not building into the budget before the budget even gets to us, because then we're going to be hit with a really big surprise. Thank you.
Thank you. And I know, Councillor, that staff have been tasked with reviewing the budget process. Maybe in an interview, you might want to bring up these kind of scenarios that are more expansive in terms of their timeline. Thank you. Okay, so the report has been duly moved and seconded by Councillor Nan, seconded by Councillor Alex Wilson. The vote is up. Faites attention, s'il vous plaît. Très bien. 13-0, it carries. Thank you. We are on 10.1, and we have about 20 minutes left on our dance card. 10.1 is the Cold Alert Threshold Review, BOH 23005A, and we also have a motion on our agenda. So I will have a mover and a seconder to put the item on the floor, moved by Councillor Taddison, seconded by Councillor McMeekin. And are there any questions on this, please? And thank you. I recognize Councillor Wang.
Thank you. Through you, Chair, a quick one. It says the recommendation is that we are holding firm on the -15 and -20 wind chill. However, throughout the report, it reads that there's a bunch of people that have said that it is still a challenge at those thresholds, and the fact that we are recommending a winter response strategy. So perhaps we can just get a very quick, super quick just explanation as to the thinking behind all of this. Through you, Chair.
Right. Thank you very much. Hello, Director McDonald.
Good afternoon, Chair Wilson. Kevin McDonald, Director of Healthy Environments Division, Public Health Services, through you to the committee. Thank you very much, Councillor Wang, for the question. You're absolutely right. We structured this recommendation report in such a way that would distinguish between the established cold alert triggers of -15 Celsius and -20 with wind chill, and that of a community winter response strategy. In looking at the evidence and literature combined with the findings and analysis from the stakeholder partner survey that's included therein for your consideration, we felt that providing these two programmatic elements separate from one another was really critical. You will see a report coming forward from our colleagues in City Housing Division. I know Michelle Baird is on virtually this morning to ECS committee next month that will detail a community winter response strategy. And really that takes it out of this realm of various triggers, slight variances. We all recognize and understand that those most vulnerable, particularly those folks who are houseless among us and at greater risk for winter climate, this will sort of set the stage for an understanding about how those various agencies in concert with one another respond throughout the season, as opposed to waiting on bated breath or hinging on a trigger.
Mm-hmm. Thank you. Councillor.
Just a question then through you, Chair. Why the -20 wind chill? Because -20 is super cold. -15 is already really cold. So wouldn't it just make sense just to have one number? So -15, both in temperature and in wind chill?
Thank you, Director.
Through the chair, Matthew Lawson, manager of the Health Hazards Vector-Borne Diseases Program. To Councillor Huang's question, the -20 wind chill is consistent with an Environment Canada weather alert, like a cold advisory alert. So from a public messaging viewpoint, it can get confusing to have so many different triggers. And as Director McDonald had already mentioned, this isn't aligned with what other health units and jurisdictions in Ontario provide at this point. It is cold, but to that end, that's why we're recommending Part B, that the services for the homeless population is addressed separately from a temperature that is a general warning to people that it's cold out and hypothermia and frostbite are more likely with these weather conditions.
Thank you, Councillor Wang. Any further questions? Seeing none. Thank you to staff for the report. A mover and a seconder on the report, I believe, Councillor Wang and Councillor Kazar. Did I do that correctly, Elsie?
I had Councillor Taddison and McMeekin.
Oh, see, just went. Thank you. Thank you to those original movers. The vote is up, please. Elsie Gauthier, I'm trying to, oh, okay, got it. That carries 11-0. We are on motions. Councillor Dan has a motion. If you're still with us, oh, sorry, Elsie Gauthier.
Councillor Nan had to leave the meeting because she's the chair of the Public Works Committee.
Right.
So she'll withdraw her motion and introduce it at the next meeting.
Oh, thank you very much. Appreciate that. Any notices of motion today? Seeing none. General information and other business. We're on to amendments of the OBL, the outstanding business list. May I have a mover and a seconder? Moved by Councillor Clark, seconded by Councillor McMeekin. Vote is up.
That vote carries 11-0.
Oh, thank you. On the adjournment, Councillor Jackson, Councillor Taddison. While we're waiting for that, on behalf of this committee, thank you to all the members of staff for your work and your diligence and for your attention today. Really appreciate it. And to clerks as well. Carries 11-0 now. Get out of here.